So I think we are streaming live now. We will resume our meeting. We had already called the meeting to order in a timely fashion. We do have a number of bills today, and we have a very important group of people who are going to testify. We look forward to learning firsthand from individuals about the bills and our agencies. I do have a couple of announcements, and then I will have my esteemed co-chair have her introductory remarks. One of them is about Senate Bill 276. This is a bill that we have raised, but we are not going to have any public hearing on that bill. We have looked at the bill because of the bandwidth issues and some of the issues with the bill. We feel that we should not have a public hearing on that bill. So I wanted to just publicly inform for the record about Senate Bill 276. Then I also wanted to remind people who are here to testify on via remote that you will be promoted or requested to be promoted. So please accept that so you can actually be part of the panel, and then you can testify when it's your turn. And with that, I'm going to ask my esteemed co-chair, Representative Kristen McCarthy-Vahey, for remarks.
Thank you so much, Senator Anwar, and I echo your thanks. Thanks to all those who are joining us online to testify today, and especially to those of you there in person. I regret that I'm not there with you today, and we'll see you together in person on Monday. I'm here ready to listen and engage in the dialogue. I'm excited to be hearing from all of those who are testifying, and I thank you, Senator Anwar, for being present in person for us and ready to go.
Perfect. And I have our ranking member, Senator Summers, next to me. Senator Summers.
Good afternoon, everyone. There's no place I'd rather be on Friday than in a public health hearing. And I'm excited to, we're going to be hearing today from a lot of our agency folks. So I think we'll get a clear understanding of what they're asking for in their bills. So I'm excited to get started. Thank you.
Good. And Representative.
Thank you, everybody, for being here today. Let's get started.
All right. And with that, we will ask our first person, that is our Commissioner, Manisha Jutani. Welcome, Commissioner. Thank you for being here, and thank you for your patience with us.
Good afternoon, everyone. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridis Ditria, and esteemed members of the Public Health Committee. Thank you for the opportunity to testify today in strong support of House Bill 5290, an act concerning the Department of Public Health's recommendation regarding various revisions to the public health statutes, and House Bill 5291, an act concerning the Department of Public Health's recommendations regarding improved opioid monitoring. I appreciate you bringing up the department's proposals at this hearing today. So in typical fashion, our various revisions bill is quite lengthy, includes several provisions that will provide improvements throughout our department. I've summarized our information to you in my written testimony on this bill, so I will refrain from further summary, but happy to take any questions you may have on various revisions. In regards to House Bill 5291, I'd like to spend the majority of my time right now to be able to explain a little bit more about what this bill will provide the department, because it will give us the opportunity to have more visibility on substances involved in non-fatal overdoses in the state. The opioid crisis in Connecticut remains critical, with up to 1,500 overdose deaths per year and over 5,000 non-fatal overdoses per year, which are being seen in our emergency departments. Most of the fatal overdoses involve fentanyl alone or in combination with other substances. But we only get toxicology reports on non-fatal overdoses from 2 hospitals at this time. So this bill will really give us the opportunity to have better eyes on emerging substances and currently used substances by doing a comprehensive toxicology test with the consent of a patient and if clinically indicated on all non-fatal overdoses that present to the emergency department. The Department of Public Health lab has the capability to do these tests, and we have a CDC grant that will fund doing these tests. So that is how we will pay for them. Currently, there are certain hospitals that do have the ability to do such testing. And we currently have 2 hospitals right now in the state that are doing those tests voluntarily themselves. So the purpose of this legislation really is to compile a comprehensive report on toxicology information for non-fatal overdoses to really give us a better understanding of where things stand so that we can respond to the emerging public health crisis as it continues to evolve and potentially modify over the days and weeks to come. So the 2 hospitals that are sending these samples are sending them to the lab right now voluntarily. What we would be doing is asking for all hospitals to potentially be able to do that. And as I said, the cost of that would be covered by a CDC grant that we have to do this purpose. So I thank you for the opportunity to testify today on these important pieces of legislation and happy to answer any questions you may have.
Thank you so much, Dr. Jani. And I think, Dr. Jani, you've said that this will be after a consent because the purpose is not for treatment, it's for surveillance purposes.
That is absolutely correct. The patient would absolutely have to consent. It is a urine specimen that is sent. And really the objective is not to inform clinical decision-making. So it can be sent as appropriate by the clinical team as they have time to be performed at the lab, really for surveillance purposes. It really is to give us not an individual patient diagnostic tool, but a population level tool for us to understand which emerging substances are potentially being used in our community. And if what we see in fatal overdoses is being mimicked in non-fatal overdoses.
And in some of the states, they are using the harm reduction centers and doing the direct understanding in the community for the various new things that are, if they are out there in the community. Has DEMAS is usually going to be looking at some of that data or information?
I would have to defer to DEMAS on that. I'm not sure on what they are doing in that regard. What I would say is that by passing this particular bill, it would allow us to partner with hospitals to provide them with the funding and resources to do those tests, but at least give us that objective patient level information that would then be compiled on a population level.
And then just one more thing, and I'll after that have other people join in the conversation. There are these synthetic opioids and other synthetic drugs that are there, and most of the hospitals do not have the capacity to identify them. So will DPH have the capacity to look at those samples and then help us out further?
Absolutely. That's part of what the goal of this grant and this particular request really is for, that DPH, because especially we have a federal grant, which is providing funding to many different states and municipalities around the country. They do have some of the most up-to-date information on the types of emerging substances that are being used in other areas of the country. And that will help us be able to identify the types of synthetic opioids that we should be looking for that might be new in our community.
Thank you. And then I'll have my co-chair. She has a question or comment, Representative Kristen McCarthy-Vahey.
Thank you very much, Mr. Chair. Commissioner, thank you so much for being here with us today and for this proposal. This is a great opportunity for all of us. I'm wondering, you mentioned that some of the hospitals in our state are doing this now. So I have a question as to the number of hospitals approximately who are doing this. And then second, if you had an opportunity to see the Connecticut Hospital Association testimony, and if so, if you wanted to respond to some of the objections that they have raised in their concerns with this bill.
So I have not had an opportunity to see their testimony, so I can't speak to that, but I can say that there are 2 hospitals that are doing this at this time.
Okay, thank you. So then I guess if I may, just to follow up, in terms of what some of the concern is related to the burden on the emergency departments. And I will preface this by saying, I think it's really important that we actually gather this information. One of the questions that the Hospital Association had is, if this information is gathered, will it then be coming back out in the form of a public report that's available to all? The question about the bill language, providing the level of specificity that reporting information will be made available and clearly communicated. Could you respond to that?
So we generate reports on opioids and opiates and other overdose information through various different mechanisms that are already in place in a number of different places. And at this point, I would have to review their testimony to fully understand exactly what their objections are. What I am saying, though, is that this is a urine specimen, so it would not be invasive per se for a patient, and it can be done, you know, along the course of other clinical workup that's happening, can be batched to be sent to the lab in a way that hopefully would not be too onerous on emergency departments.
Thank you, Commissioner. And I think I'm not sure if you can actually see me. I can't remember if there is a monitor, so that's wonderful. I appreciate your answers, and I know that we work always in partnership with the Connecticut Hospital Association and with you, the department. This is an epidemic, and we need to continue to gather data that's going to effectively help us to know where and how we can intervene. So I look forward to working with you and the Hospital Association to try and advance this conversation. And thank you for your testimony today.
Thank you.
Thank you. I have Representative Mara online and then Representative Cook after that.
Thank you so much, Mr. Chair, and thank you, Commissioner, for your testimony today. I couldn't agree with you more. We need to know what all we're dealing with. So I do appreciate your testimony. One of the things that, and I know this is a bit in transportation, but I just would like to have your thoughts on it, because this is obviously a health risk that we have too with some of the road fatalities that we have. And one of the issues that we have is when we find a primary intoxicating substance, we stop. For instance, if we see alcohol in someone's blood, then that's the end of the discussion, and we don't know what other chemicals or effects that they may have in their blood. Do you have any thoughts on that, and whether we should be looking for extra substances when we deal with, like, obviously with road fatalities, we get the full toxicology back on that, but when we have other accidents that have intoxicating substances?
So I think specifically to your question, if somebody presented to an emergency department and supposedly, let's say, had an accident, as you're describing, but they presented to the emergency department and are identified as having a non-fatal overdose in that context, this type of testing would actually help us with that, because it would actually evaluate what is in the urine and any number of potential medications, or in this situation, really overdose specimens that could potentially be there that would be tested. So I do think that this would help inform what you're getting at. I don't think I can comment on what the value would be of doing that on site. For example, I think that's what you're mentioning in terms of, initial testing that would be done. I'd have to defer to other commissioners on that. But I do think this would help us get more visualization on if somebody actually came to the emergency department and had a traffic incident, for example, what was in their system.
Okay, thank you. Yeah, no, I guess I'm looking at, sometimes, we think of traffic accidents as separate issues, but I'm kind of looking at it when we have intoxicating substances in people's body, that we're actually dealing a little bit more with a public health issue, because it's sometimes I think we don't always know when it's only alcohol or when there's other substances added in, how that actually affects driving. And just like you mentioned, when you're doing like a full toxicology of how the other drugs, what other drugs we may be seeing that are out there, I think that might be the same. It might give us more insight with, a public health issue with our traffic incidents too. But anyway, thank you so much. I appreciate your comments today, and I appreciate your testimony. Thank you, Mr. Chair.
I will just also add that the Transportation Commissioner does bring together Public Health Commissioner, Police and Safety Commissioner, and Transportation to talk about issues like this. So those are forums for us to do that.
Okay, great. Thank you so much.
Rep Cook.
Thank you, Mr. Chair. Nice to see you, Commissioner. Two quick questions. My first question would be, so I hear the conversation about no one would be able or would be required to administer the test unless they give their consent. But there will be the conversation about the fact that if the police determine that there is a need, would they be required to do that under a police directive?
So that may be a different reason. There may be a different, and that would not necessarily be covered by this particular proposal. So I can't really speak to the laws on that in terms of what might be required and what might not, but this would not require that. So this is really if there was patient consent that they were willing to provide a urine specimen for this surveillance purpose, that we could do that.
Okay, thank you. And then my next question, are you prepared to comment on the sections 1 and 2 under birth certificates?
Yes.
So I'm just trying to understand, and I know that we talked primarily about the subject that we had just discussed, but I'm trying to understand the necessity for the change in language where we talk about legal guardian versus legal custodian. If you could elaborate on that a little bit and what the need for the changes?
Yes. So the responsibilities granted to a legal custodian are substantially similar to a legal guardian, but using the term guardian versus custodian is more restrictive. So if somebody has a legal custodian designation, it would give them the ability to do what they need to do for this purpose. In terms of being able to obtain a birth certificate, that's really the major reason.
So I guess my concern is ensuring that the wrong hands don't access a birth certificate.
Right.
Right. So you could have temporary custody in theory, but not legal guardianship. So who would be the determining factor on whether or not somebody was able to access someone's birth certificate?
This is a legal term in terms of legal custodian. I would need to get back to you further if there's specific, concerns about this specific terminology. This is something that's definitely been asked for us because of challenges in the system, but we will definitely, and I think it's the probate court that would ultimately decide that in terms of that designation.
But traditionally, a birth certificate would be accessed through the city clerk's office of wherever that child was born. So my concern, Mr. Chairman, would be the fact that somebody could access a birth certificate that should not be accessing the birth certificate. So depending on guardianship and legal, you don't want to say ownership of a child, but they're my children. And if somebody has temporary custody, I would just be concerned on how that plays and who's able to access that. So I think before we do anything further, I would like some clarification on that piece specifically.
Okay.
With all of the stealing of identities and you fill in the blank on everything else, I just want to ensure that we protect first and foremost the child and make sure that that is done in a very appropriate manner. So thank you for any information that you could give back before we might have to take a vote on this.
Okay.
Thank you, Mr. Chair.
Thank
Thank
you. Representative Berger Giballo.
Thank you, Mr. Chair, and thank you so much for all of this information on your support. I actually was concerned about a few of the questions ago when it was asked about the legal piece of it, the criminal legal piece, and I wanted to ensure that we separate these two things. I think that's it's easy to conflate those two when we're having this conversation, and they are. With my experience in transportation, nobody works in silos. The commissioners of each of these departments is contributing in a way that is meaningful and quite helpful. So with that said, I would love to know, have you considered the rate of consent? Because I think when we have conversations like this where we conflate these two, it might make folks fearful to consent to contributing their data, their information to this pool. Which we know would be very helpful. Do you have any thoughts about whether consideration for consent would be limited? And is this enough to really ensure that we get the kind of data we're looking for?
So I don't have a full knowledge of what the denominator would be and with consent where we would go. I don't have that information. But I do think that because this is for surveillance purposes, that asking for consent is what we would like to do. And I think because of that, even though we may not get 100%. Even if we get, right now, we have nothing in terms of I mean, not nothing. We have 2 hospitals that are doing this right now. But if we had a broader spectrum across the state of various hospitals where we could even get an inkling of what's happening, I think that would still be very powerful surveillance information for us to have.
Thank you. And I do not disagree. And I think maybe it could be something that falls on our shoulders to make sure that we communicate that this is not in any way intended to be an implication of criminality. So
Absolutely.
thank you so much.
Thank you.
My co-chair has a question or comment to Representative Kristen McCarthy-Vahey.
Thank you, Mr. Chair. Mr. Chair, just a thought that Representative Cook is asking some clarifications in the commissioner reference probate court. We do have a probate court administrator testifying, and perhaps we should ask that question when she is before us. Thank you.
Thank you. With that, we have Representative Clarice Deidre, followed by Representative Zupkus, then Senator Gordon and Representative Parker.
Thank you, Mr.
and
Chair.
Representative Wheeler.
Thank you, Commissioner. Sorry for being here today. To go back to the grant, the federal grant that you were speaking to earlier, how long will that federal grant, those monies last?
5 years.
Thank you.
Thank you.
That was easy. Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming today. 2 questions. You keep mentioning 2 hospitals that already do this. Who are the 2 hospitals?
I had a feeling you might ask that, and I don't want to say it out loud. I have it in the top of my head, but I don't want to say it unless I have it exactly right. So I'm going to ask my team if they can clarify for me to know for sure. If you could introduce yourself.
Hi, I'm Miriam Miller. I'm Policy Director for the Department of Public Health. The 2 hospitals are Bristol Hospital and Hartford Healthcare.
Thank you.
That's what I thought, but I didn't want to say it unless I was 100% sure.
And then my second and last question is, you were talking about the difference between legal guardian and legal custodian, and you said guardian is more limited. Can you just explain why?
So I think I'm not the best person to answer this question. That is my understanding of the 2 terms. But since it has been brought up that there is somebody from probate court that is going to be testifying, I would ask if maybe they can provide that clarity, because I don't have full knowledge of the exact difference between the 2.
Okay, so that's their part of their bill in the bill that you're supporting this bill, right?
You're talking about this various revisions bill? That is correct. However, I cannot, I apologize, give you an exact distinction between custodian and guardian from a legal standpoint.
Okay, I will ask them.
Thank you.
Senator Gordon.
Thank you, Mr. Chairman. Commissioner, thank you for being here today.
Thank you.
I have 2 questions. One is about Raise Bill 5291. If you haven't read the submitted testimony by the Connecticut Hospital Association, I definitely encourage you do. They actually raise a very good point. You had mentioned that the CDC grant is for 5 years. If this bill passes, there's certainly a concern, and I agree with the concern raised by the Connecticut Hospital Association, that this bill doesn't have a sunset. So if the grant ends and there's no continuation of the grant or new grant, this law, if it were to pass, continues, which means how does it get paid for? And so I would ask, my question to you is, number one, when you do read their testimony, if you could get back to me about your thoughts, and to the committee about the suggestion raised about having a sunset provision in this bill to mirror the length of time of the CDC grant. And if it turns out that we get another CDC grant, which would be great, because I understand the medical and public health aspects of this, so I appreciate you wanting to look into this. This is helpful information for us to be able to track. Then we can always extend it. But I would just ask if you could let us, and through the chairs, know what your thoughts are after you read the suggestion by the Connecticut Hospital Association, if you could.
We will do that.
Thank you. And then my last question for now, Mr. Chairman, is there's testimony that's been submitted by the Eastern Highlands Health District. They do very good work. They do cover a number of towns in my district, Senate district in Northeast Connecticut, where we do have issues with most people have wells like I do in my part of the state. And in some of the towns served by the Eastern Highlands Health District, there is a massive salt contamination problem, which I know your department is well aware of. And I've been to those meetings out in Tallinn, for example, and I appreciate your department being involved on the ground. So thank you for that. But they do raise a concern in their testimony. I don't know if you've read it yet or not, about section 16C raising a concern regarding disclosure of private well water quality lab test results and how that might potentially hamper public knowing about contamination of water. You know, certainly salt is a big one. As we know in our part of the state, including parts of New England, arsenic is also a real issue. Hence why when I built my house and put my well in, I tested for arsenic and wasn't surprised to see sky-high levels of it. So I'd be interested, if you have read their testimony, if you could address or let us know your concerns that they raise regarding trying for them to serve the public so people know what's happening with the well water, especially if someone is going to build a house and put the well in, but if going to want to sell a house or buy a house that's already existing, knowing what this information is, because unfortunately it is a very serious public health issue that, again, I know your department's aware of. So I'd be interested in your comments, and if you haven't yet read their testimony, if you're able to get back to us about their what I think are very serious and legitimate concerns.
So a few comments I would make are that the labs are required to send us testing that is done of wells already. One of the reasons we put this provision into various revisions is because of concerns from local health departments on confusing and different interpretation of language from the statutes that have been in place. Local health authorities have been concerned about confidentiality provisions that are there, and there's been confusion among them on what can be released and when cannot be released. So this is why, in working with our local health departments, we put this forward within this various revisions. So I have not read their testimony yet. I will read that to be able to understand further what it is that they have specific concerns on. But what I can tell you is that because there's been challenges and consistency across what information is shared and whom it is shared with, this is why we have tried to clarify it.
And thank you. I appreciate that. And I would definitely encourage you to read the testimony from Robert Miller, who's the Director of Health of Eastern Highlands Health District. And I'd be very interested in, when you do, what you think about the concerns that he raised. They do cover a number of towns, and some of which have the salt contamination. And that's also his, factoring into his concerns as well with regards to that. So I look forward to that. Thank you, Mr. Chairman.
Thank you, Representative Parker.
Thank you, Mr. Chair. Thank you, Commissioner, for being here and all your work and your team. I just want to follow up on the funding for the surveillance program. And I appreciate you lifting up the concept of surveillance. That was really resonant too, thinking that this is not necessarily intended to capture every single person. It's giving us that breadth and that sense of what's going on. Can you just speak a bit about what that grant would actually pay for? Are those services inside of DPH? Is there funding available to get out to hospitals and EDs to do some of that collecting? And wondering if this is something that's in the budget currently and sort of what the impact of that might look like.
So we don't have funding within that grant to be able to provide support to personnel, for example. I believe that's what you're trying to get at in terms of, nursing time or something to collect a urine specimen. DPH is 80% federally funded. Most of our funding comes for programs like this. We've got about 15% or so, 18% that's state funded roughly. The rest is for programs like this, and some of which we have statutes that actually support the type of work that we do that support those grants. Some of them we kind of mostly get renewed over and over, and not all of those statutes have end dates. So I do understand, though, the challenge with that in this sort of situation, because we have gotten this grant a few times, but can I promise you in 5 years that we'll get it again? I don't know that. But I will say that we have a number of different supports within this OD2A grant for doing work in communities around opioids in general. I don't think we have funding within that grant, though, to support personnel time, the way that it has been funded.
Thank you. So the funding is primarily to cover the cost that would be associated inside the
For the lab testing
agency, the
itself.
lab test. Okay,
Right, at our state lab.
great. Thank you. Appreciate your time. Thanks,
Thank
Mr.
you.
Chair.
Thank you, Representative Wieland.
Thank you, Mr. Chair. Good morning, or actually good afternoon. I had a couple of questions about the opioid screening. One of them is that in the language, there doesn't seem to be anything about ensuring that anything that's collected is de-identified, and so it remains anonymous. Is that something that is currently in practice with the two hospitals that are doing it, and will that be continuing?
So I might have to get back to you on exactly when a specimen goes from the hospital to our lab, how it is labeled. And I can't say that I know exactly how the hospitals are labeling it from the two hospitals that are currently doing it, both Hartford and Bristol. What I would say, though, is the purpose of using the data is not on an individual patient basis, is not for clinical purposes. It is for surveillance. It's for more population health purposes. So in terms of the output of the data, it would be in that broad way that we are hoping to utilize it in terms of the way that we want to use the data.
I understand the intent, and I think we're all are aware that this is a growing issue, but we are looking to avoid any legal complications or anything
Absolutely.
that could come back. It would be important to ensure that it is completely de-identified and wouldn't end up causing problems for the people submitting the sample.
May I give one additional clarification, which is that we have a confidentiality statute 19A-25 for DPH. All of this data would be confidential under that. So for the purposes that you're saying in terms of how somebody could potentially use the data inappropriately because it's confidential, I do not believe that that is an actual risk.
Okay, clarification on that would be very welcome. Thank you. And is there a turnaround time that we would be able to use? Is it done quickly enough, the results on this type of screening, that we could use that information for treatment? Looking at the Connecticut Hospital Association's testimony, they were concerned about the additional push and whether or not on the requirements for the personnel and staff, and would it actually be useful in the long run? Is there a turnaround time that you're aware of?
So I'd have to get back to you on the exact turnaround time on these specimens. What I would say is what we're asking hospitals to do is that, again, this is a urine test. They may do routine testing that they would do to inform the clinical care of the patient that they may need immediately, within an hour or something like that. This is an off-site lab, so it's not going to be as fast as whatever they're doing in-house. That I can certainly say. So we'll have to get back to you with the exact turnaround time from when it reaches the lab. So it would need to be couriered to the lab and then, actually be tested there and then be able to provide the result.
Thank you. And Mr. Chair, may I ask one more question?
Please.
Thank you. In shifting to the revisions bill in 5290, Section 3 talks about the notification of any changes to watershed areas. Can you clarify that and let me know, or the committee know, please? Does that notification extend to residents or any public facing platform that would allow people who are adjacent to those areas be aware of potential changes? Many people in my district and across the state have wells, and they may not be directly in the watershed area, but could be adjacent, and any changes I think would be something that they would want to be aware of.
So the question is whether we would be notifying adjacent properties or if those adjacent properties would notify us. I just want to clarify that we get the right answer for you.
Sorry about that. The change in the section seems to be saying that the Department of Health and the water companies that are on site of that watershed area, if there was any changes to that, if there was like the current term project, I think was the concern. But if any changes were to happen, is it just DPH and the water companies that are notified, or is that notification extend to a public facing platform or to the residents of that general area?
So currently notification is required to DPH and a water company.
Mhm.
The use of the word project in the current statute is what has created confusion. So what we're trying to do is not change the notification structure, is to clarify when such notifications should be submitted. We're trying to clarify what the use of the word project means. That is what has been changed.
And I think that gets to my concern that a project is something that potentially has to go through public planning and zoning conversations. There might be notification for meetings that residents and the public may be aware of. If it's just a change to the area, that may not be as well publicized. And again, if we're talking about something that could impact a personal water drinking supply, it would be helpful to have that change also be publicized to the residents. Thank you.
Thank
Mr.
you.
Chair.
Thank you. Commissioner, I had just a couple of questions as well. For 5291, this screening, not the screening, but the testing that we are going to do, would that be extended to the children? Because we are now seeing some children with accidental overdoses with signs and symptoms of an overdose.
If there is consent provided, then the specimen could be sent.
Okay, so that covers that. Good. And from the Environment Committee, we got a request for the Connecticut Environmental Health Association reached out to them and to us and everybody for some of the definition changes to be inclusive, to keep the for 5290, they say we would fully support the bill if edited to include both titles, or sanitarian and environmental health specialist. I don't know if this came to us a little later and then you've received something like this too or not.
So we have worked with CIHA and our local health departments extensively on some of these issues over the last several years. One of the challenges is that the term sanitarian is sort of an antiquated term and has been proposed to us for us to consider changing it to environmental health specialist. So if the industry feels that they have other thoughts on this, we're happy to learn more. It seems that this transition to what they're looking for may be something that they think may not be able to do the job in the way that they're doing now. We will have to look into their comments further.
Okay, so this is important. I think this is what they're saying in their letter is that they have some 300 members and looks like some of their members may have raised concern to them, and that's why probably they're having second thoughts.
Right. I mean, what I would say is that there will be no change to the certification process or their ability to conduct inspections. This name change would not change their certification process or their ability to conduct inspections. So if the concern is that that would somehow change that, that would not be the case.
Good. Seeing no other comments, Senator Gordon.
I'll be real quick, Mr. Chairman. I just want to follow up on what you said, Mr. Chairman. I think it is a real concern. I used to serve on a local public health board for a number of years. And I think if they're raising the concern about those two distinctions, and I don't know if you've had a chance to read their testimony or not, but they do talk about one being a state credential, another being a national credential. It would seem to me if there is anything that they need to have clarified, so that way, other than us just saying or hearing today, yes, there wouldn't be any concern in what they're duly authorized by law to do. If we can clarify that in this proposed bill, all the better. So I would just ask that you take a look at their testimony and liaison further with them. I understand their concern very well. What they're proposing to me would seem to be a very simple fix. That way it's clear and there's no confusion later on if this bill were to pass. Thank you.
Thank you.
Thank you, Mr. Chairman.
Thank you. I just wanted to make a quick comment, Commissioner, for the various revisions with so many things, each sentence is associated with many hours of meeting of your staff. So we truly appreciate the work that has gone on behind the scenes and communications and conversations. So we thank you for the work that you're doing and thank Thank you for your testimony today.
Thank you very much for this opportunity.
Thank you. The next person is number 2 on the list is Sarah Egan, Office of Child Advocate. Welcome.
Good afternoon to the committee. My name is Sarah Egan. I run the state's Office of the Child Advocate, which is an independent oversight agency charged with investigating concerns about children and issuing recommendations for system improvement. I just wanted to comment really quickly on the last bill that we didn't submit written testimony on DPH's bill regarding opioid surveillance, which I think is a really important bill. And I appreciate, Senator Anwar, your question about implications for children, because we do know that children are presenting to young children under the age of 5. We've had 45 fatalities and near fatalities of children under the age of 5 since 2020, presenting to hospitals and emergency departments with opioid overdoses. Many of those children have survived due to the administration of naloxone by first responders. It is my understanding that most, but not all, emergency departments test children for synthetic opioids. We had talked with the Connecticut Hospital Association in the past year about that. They were working to make sure that that was universal across the board. But just thinking about that in connection with this, I think, important bill from DPH and making sure that I think it will be important to confirm with the Hospital Association that all emergency departments treating children for symptoms of possible overdose are routinely testing for synthetic opioids. I think that's close to true, but I don't know that it's 100%. So I just wanted to make that's an issue that's on our radar that we agree is extremely important, and that surveillance data disaggregated by age would also be really important to have and to know. And of course, our teenagers also come across opioids as well. But we are here to testify and offer comments and some recommendations for the committee's consideration around the 2 DDS bills, 5292 and 5293. The Office of the Child Advocate in particular supports provisions in House Bill 5293, which provide for the establishment of human rights and program review committees in each of the department's service regions, as such committees can further advise the department regarding the provision of safe and high-quality care and services for disabled individuals. But I wanted to call to the attention of this committee an investigation that our office published just a couple of months ago that has implications for the need to strengthen further, and I think probably to a substantial degree, the regulatory framework for ensuring the safety and quality of care for individuals, including children with IDD, in DDS licensed community living arrangements, which the state has several hundred across the board, mostly serving adults, but not exclusively. We published an investigation in November that because of a critical incident in a DDS licensed CLA that involved a minor youth and a young adult woman living in the group home, that led us to conduct a much wider investigation into the adequacy of the regulatory oversight for the state's probably 700 to 800 CLAs.
Excuse me, Ms. Egan, but your time is up. Thank you.
My question was, could you complete your testimony?
Thank you. Thank you. Appreciate that. And what we were looking at was the adequacy of of the oversight framework for the homes in terms of preventing, reporting, and responding to critical incidents, including concerns of abuse or neglect of intellectually disabled children and adults. We did find widespread concerns there. And those concerns were first seen, just to back up for 1 second, and I'll go quickly through it, in a 2016 federal report from the Office of Inspector General for the U.S. Department of Health and Human Services, looking at some of the same issues, which found that Connecticut was not in compliance with Medicaid requirements for safety for recipients of home and community-based waiver benefits, which is the fund that pays for a lot of the beds in these DDS licensed community living arrangements. So HHS had found that we were not adequately reporting and responding to concerns of abuse and neglect in these homes. Our investigation, culminating in a published report in 2023, made a lot of the same findings, that there continued to be a problem of prompt or even any report of a critical incident, including of abuse or neglect, in homes throughout the state, that the regulatory response from DDS was sometimes slow, sometimes inadequate. Some homes were not necessarily revisited. The majority of homes we looked at were not revisited for 2 years by licensing regulators. And that in a nutshell, a lot of work needed to be done to tighten up this regulatory framework. Both DDS and DSS, that has a responsibility as the payer for a lot of these beds, worked with us throughout our investigation, committed to certain steps to improve quality assurance, detection, and follow-up on critical incidents, which was a really important first step. But I think there's more work that needs to be done. The Office of Inspector General, Federal, did a re-audit of Connecticut and published its most recent report 8 weeks ago, which we include some highlights of in our testimony. That re-audit by the feds, published in December 2023, and I'm just going to quote quickly from that, found that Connecticut had made changes for the better since the previous report, but that Connecticut still did not ensure that group homes reported all incidents involving potential abuse and neglect to DDS because group homes experienced significant staff hiring and retention problems, and the state agency and DDS did not implement new analytical procedures to detect incidents involving potential abuse and neglect during the audit period, where OIG found 163 incidents of potential abuse and neglect that were not reported to DDS. And then OIG made a number of recommendations, which the state concurred with and indicated that it would need some resources to implement. So I wanted to bring that to the committee's attention because these are current issues impacting safety and quality of care for many vulnerable individuals in state-run, state-licensed community living arrangements. We want to continue to work with DDS and DSS on these issues. We're going to be meeting with some folks from DDS next week to talk about next steps from the OIG report. But to the extent that this committee has a vehicle in these two bills to improve aspects of the regulatory framework for DDS to the benefit of these individuals, I would like an opportunity to also work with the agencies and maybe submit some additional language to the committee for your consideration. We did make a number of recommendations in our report to improve the licensing framework, but also, frankly, to improve the public progress monitoring for these issues. These are urgent safety and quality of care issues for some of the state's most vulnerable individuals. And I cannot find on any public framework on the websites, on CGA's website, on DDS's website for discussion about these types of findings and what the remedies are going to be. I think that's going to be really important too. I'll wrap there because I know I've gone way over my time. Thank you for letting
Thank
me
you
do
so much. So 5293 is you're in agreement with what's there, but you feel there's an opportunity to improve further with the background that you have stated.
Correct.
And you're also offering your office to work with DDS and perhaps DSS. Well, DSS has other bills, but DDS at least in this bill to be able to create that framework to address the Office of Inspector General's recommendations.
Correct. Yes.
Okay,
Senator.
this is very helpful. Your office does God's work. So thank you for all that you do. Each and every department does amazing work in our state, and that's why we are blessed in our state to do so well. So Representative Zupkus, please.
Thank you, Mr. Chair. Thank you. Nice to see you. You always come with great insight and solutions. So I'm really grateful. I'm sure we all are for that. As you probably are aware, there was an issue in Harwington, not with young girls. And so people reacted, and I think it's closed now. We don't want this to happen at these places, at any place. Could you just tell me, just so I'm clear and understand, these group homes that you're talking about that fall under two state agencies, the state has oversight of them, but does not run them. Who are they run by?
Yeah, so the Harwinton home is a DCF licensed star home, shelter model of care. So DCF contracts, same on the DDS side for the most part, right? The state agency contracts with the community provider to run these homes pursuant to the state's regulatory criteria with expectations around quality of care, what the expectations are, and the contract expectations. So that's how so it's private, it's privately run, state licensed.
So the private company has a obligation to make sure people are safe, but the state also is obligated. And so to me, with same as Harwinton, as what I'm hearing from you is that is not happening. And who is accountable for that? To me, it sounds like both are.
Correct.
But ultimately it is the state, and they're state funded. So
yeah, and we talk about this in our report. It's both pieces, right? So the regulatory framework has to be adequately. So why does DDS not go out for 2 years to a home, even where it found serious concerns? What they told to us is that because of resources, they triage that, right? So they'll revisit in a 12-month period about 20% of homes. We found that to be true when we did our own sample, and we looked at the licensing records of about 150 DDS licensed CLAs. We found in that sample 49 over a 5-year period that had been cited for regulatory violations for failure to report harm or failure to have a system for reporting harm. Of that 49 in that 5-year period, only 2 were revisited by licensing staff within 30 days. Most were not revisited within 2 years. Now, that doesn't mean nobody comes out to the home, a case manager, a nurse, whomever, but the regulator is not coming back out, right? That's a resource issue. That's why that happens. So what we want to be doing is coming out more often, right? Sometimes probably unannounced. So the regulatory piece has to be funded adequately to oversee, particularly for a population of individuals that may have impaired ability to report harm. But the second piece, and I'm grateful for the opportunity to stress this, is we have to pay people on the community provider side to do the work. And the OIG made that finding that without the staff recruitment and retention at the provider level, if we don't deal with that funding crisis, then we can't guarantee safe, high quality care on a consistent basis to vulnerable people. You know, providers want to provide that care, but they need to be able to staff and support those homes. And that has to be paid for.
thank you.
Thank you for the
And
question.
you're right. And we all know that staffing is an issue. Paying people isn't, I mean, we hear it in every committee everywhere. However, if people are getting harmed, something has to be done.
Correct.
Thank you.
Representative Cook.
Thank you, Mr. Chairman. And I just want to go a little bit deeper into this. So there's no words when we put children in harm's way, or people in harm's way for that matter. So if we're talking about reporting and all of the other things, and we're talking about lack of staffing and you fill in the blank, what are we doing about training? Because, you know, there's several locations out there that are just hiring staff to hire staff because you need to put, you know, a body in a position so you can keep the facility open, but those staff are not being trained and they're not being trained appropriately. So what does that look like? Because we can talk about reporting and we can talk about all these other things, but if the staff are not certified and trained in an appropriate manner, it's just going to continue to happen.
Yeah, that's a great question. So in the 2016 OIG audit, one of the things they recommended to the state was that it improve its policies around abuse, neglect issues, improve training, make sure providers are trained. OIG did find in the re-audit that DDS, working with DSS, right, because DSS is the funder of a lot of this, did make a lot of strides with that. However, in the OIG re-audit, which was just published, they continue to find that that's a struggle, right? Because if you're churning employees, right, the reality is that some of them, percentage I don't know, are providing direct care without adequate training because you have to. because you've just brought them in. It's not that different from the Star Home issues, right? You're bringing people in, they do the best they can. They may or may not be trained fully before they're responsible for extremely vulnerable individuals. And that's not a recipe for the kind of care we want to ensure for people.
Thank you. Very insightful. Thank you so much. Oh, Representative Reddington Hughes.
Thank you. My question has to do with the punitive part of this bill, that, you know, I certainly understand that, you know, under many circumstances, things happen, but when a home is found guilty of something that will lead an indelible mark on a child or a young adult, and we're talking about the most vulnerable population. So these are people that in many cases really don't have a voice of their own. That the result of this is a $1,000 fine or, you know, 6 months. It just seems very strange to me that that is what the damages would be.
So I don't have that provision of the bill right in front of me, but I would say that in general, you know, whenever a child or a person is harmed through failure to adhere to a standard of care, there are a host of remedies at that family's disposal. And it's in my role, I have seen families avail themselves of those remedies to be compensated.
Oh, certainly, and I agree with you. I'm just worried that when somebody's running one of these operations and they're not really doing a good job of it, that this doesn't really seem much of a deterrent. Thank you.
Yeah, thank you.
Representative Wiehlander, thank you.
Thank you, Mr. Chair. Good to see you again. This comment and question might seem redundant based on our conversation yesterday. And I think it's really frustrating that we're having this conversation again, where we are seeing a residence that is chronically understaffed by people who are chronically underpaid. And then we have an agency that is having to, you know, is in a position where they, for whatever reason, for budgetary decisions before my time, we are relying on private companies or nonprofits to do the staffing for and the care of the people who are ultimately under the charge and the responsibility of that agency. And I can't help but think, and I guess this is more of a comment, but I'd love to hear your thoughts on it as well, that we would have a more streamlined and direct line of care if the agency was actually employing the people who were doing the work, so that if there were issues, it was in that line of sight of the people who were supposed to be responsible and overseeing these charges. Do you feel that would make things more effective in terms of care and oversight?
Just want to make sure Representative Wiehlander.
It's a long question, sorry.
Went in a different direction than I expected. That the state would employ folks? Is that what you're talking about?
Yes.
Oh, that's an interesting question. I mean, it's certainly there's always been a mix of that, right? But the state has, shifted many, many years ago to relying on its nonprofit system to do the essential work of caring for vulnerable people, right? And while we come in with our grim and our harsh findings, right, because that's our job, right?
Mm-hmm.
The provider, we have tremendous respect for the provider community. I talk to providers, people doing work on the ground every single day. And without exception, they are dedicated to fulfilling their responsibility. But we have not supported that system, period. Right? We talked about this yesterday in the Children's Committee about behavioral health. We can't underfund it and then expect the consistent quality of care that individuals deserve, that their loved ones count on. The incident that started our investigation involved a teenage boy who has autism, is intellectually disabled, is functionally nonverbal, who'd been in foster care for 4 years, and another young person who was a young adult who also was developmentally disabled, nonverbal. They and their families are entirely dependent on this system of care. The majority of other individuals in that home were nonverbal, right? So even if you have folks coming out, which is good, you have a nurse, you have a case manager, occasionally you have a licensing regulator. The system can't keep looking like what it looks like, in my opinion, right? For people who are that vulnerable. And it does start, I think, with looking at how we're resourced, what are the obligations of the system, and is it resourced to do that? And then you can expect what you want to expect from it, right? But we're struggling there. And I know DDS I respect its mission, it's working on these issues, but I just think they need to be aired. And we need a framework for accountability. And every year when those Medicaid HCBS waiver applications get looked at by the legislature, we should be looking at this.
Thank you for that. And I appreciate your time and attention on it. I think this is a major issue that we need to be paying more attention to, and also start having more of a discussion about the perceived value of the work and the value of the people who are receiving the care. So thank you very much for your time.
Thank you so much for your questions. I'll just make the statement I probably made yesterday at the Children's Committee hearing. It was just like deja vu that we have created amazing systems that should work, but then we stop paying into it and then they actually erode, and then we send money and then spend money to try and understand. And the research study comes and says, you're not paying people enough. And then you say, oh, well, you sort of know that. So that's where we are with this as well. And it's this is preventable and this is a priority, and we should be looking into this. And I'm sure we'll have conversations with DDS as they come and speak. Thank you for your testimony. Appreciate you and your team.
Senator Albert, just wanted to make one final comment just to put a fine point on it, that I have so much respect for the people that do direct care work. So I just wanted that to be said. It's challenging. It can be very gratifying. And, I'm here in my professional role, but I'm also the parent of a child who's developmentally disabled, fairly significantly, and who does not talk, and who can't even really use an assistive communication device effectively. And I can't process that too deeply, that I send her out into the world every day, and I am dependent for her and for myself on the lovely, amazing people that work with her, that sit with her on the bus, that help her eat her lunch, that take her to the bathroom, that help her get dressed. And then she comes home to me at the end of the day. And I trust and I'm so grateful for all these people who care for her. And I look out into the future and I think about the kids in these placements and the older people in these placements and their families. And I have respect for everybody that contributes to that system, particularly the people doing the work. But we have to be rigorously honest that we have a lot of work to do to make this look the way it needs to do. So I just wanted to acknowledge that personal element and my respect for the people who get up every day to serve and to work with and to support the quality of life for disabled individuals. So thank you for the opportunity.
Rep. Berger-Jawalu has a comment.
I just want to comment that I am truly grateful to you for sharing such a personal piece. I think that when we do this work, we sit down to really look at all the data and the details, and we forget that there are people who are truly affected by the things that we do, that you do, who kind of keep that quiet just to get the work done. And without those stories, the work almost feels meaningless. So thank you very, very much.
Thank you. Thank you. And the next person on our list is number 3, Beverly Strait Kefalis. Welcome. And thank you for being here.
Thank you, Senator Anwar. Representative, I think Chrissy Vahey is here remotely, Senator Summers, Representative Clarice Ditria, and the honorable members of the Public Health Committee. I have to say, having heard that testimony and hearing the questions, I continue to be incredibly grateful for this committee and so many others, and officials like Sarah Egan to make sure that we are all reminded about our role in protecting vulnerable residents in our state. Many of you may know, but in the probate court system, and I think I neglected to identify myself, I am Beverly Strike Kafalis, the probate court administrator. More than half of the work in the probate court system is not trust and estate work. It is in fact matters that involve protections and family-centered solutions to protect vulnerable residents in the state, children, adults, from all areas of concern, whether they have dementia, intellectual disabilities, parents with substance use disorders, psychiatric disabilities, all of those vulnerable constituents often come to the probate courts for protection and to ensure that the laws are meeting their needs. So I just wanted to say how much I appreciate the attention of this committee and so many other public agencies to make sure that those citizens and residents are protected. I am here to testify specifically on House Bill 5290, which is the Department of Public Health's recommendations on various public health statutes. Specifically, I do support the concepts in Section 1. Section 2, I have concerns about Section 7. I have submitted written testimony. I would just like to highlight a couple of points. One, in Section 1, that proposes changes to Section 7-48C, which is a statute that right now addresses how parents can obtain a birth certificate when a child is born outside an institution. So in other words, a home birth. Right now, when a parent, for a variety of reasons, is unable to comply with the regulatory requirements to obtain that birth certificate, they have to wait until the minor is 1 year of age in order to obtain that delayed registration that is provided for in Section 7-57. The bill proposes, and the probate court system supports, having a similar probate court procedure to address those types of petitions when the registrar of vital statistics is unable to issue that certificate. I just do offer some specific changes to be in conformity with the provisions of 7-57. One specifically is both provisions now would say that on the child's first birthday, you could either proceed under 7-48 or you could proceed under 7-57. So I would suggest Section 1 be revised to say that prior to the child's birth. And also request conformity so that the court order is consistent in ordering parentage as well as the date and place of birth of that child, and genetic testing procedures that are set forth in sections 46B-495 through 46B-500. Section 2 is actually, I think, Representative Cook, and I thank you for your questions on that, which I'd like to clarify. That is a proposal by the Department of Public Health. The language right now in the statute merely says a guardian has the right to obtain that birth certificate. We had, in the proposal initially, I believe, was to add a court-appointed guardian or a legal custodian. We would support language that makes it clear that is a court-appointed guardian and a court-appointed custodian. And what that language does is offers to the registrar of vital statistics, which is typically the town clerks, objective, verifiable documentation that that person is authorized to obtain the birth certificate. And a custodian is important to have it so that they can register the child in school, daycare, obtain routine and emergency medical treatment. So there's certainly appropriate reasons that a custodian should have it, but we would want our town clerks to have a legal document that supports their expression that they are in fact a custodian. So thank you for that question, Representative Cook.
Excuse me, Ms. Kafalis, your time is up.
If you could complete your testimony.
Thank you.
Other parts?
I would just offer on section 7, I have had in-depth conversations with the Department of Public Health. I do have concerns about removing the witness requirement to MULS throughout the country. Sometimes they're called a PULSed. In Connecticut, they are a MULSed, and there are a variety of witness requirements to those documents. And we will continue to work with the Department of Public Health and perhaps come to the committee with substitute language. I do think having the authenticity and the validation of a patient's signature on that MULSed is important, and that's why a witness is required in a multitude of documents in our state and throughout the country. And I do think it's important that at a critical person's time in a person's life, that additional validation of their signature is part of that process. If I could offer just quickly comments about Senate Bill 243, which is the Department of Developmental Services bill regarding, I'm misspeaking. That is the one about Assertive Community Treatment Pilot Program for Home Health Agencies. I understand the intention of that legislation is to ensure protection for the workers in those homes. I would just offer anecdotally that the individuals who have the behavioral health issues that are being served by those home care providers are often under conservatorship in the probate court. And I think having a pilot program that evaluates the totality of that system, as well as ensuring collaboration with all the stakeholders in that person's care, will also not only benefit that individual, it will protect the workers, which is so paramount here, but also would, I think, help to alleviate some of the major strains in the healthcare systems and the probate courts and on the conservators who work very hard to ensure someone's individual rights to live in the community with the necessary supports continue. So I just would offer that anecdotal. And then finally, House Bill 5292, it is the Department of Developmental recommendation. It is a bill that proposes sharing of otherwise confidential information when a person, entity, or agency has had a substantiation of abuse or neglect regarding an adult or a child with intellectual disability. Again, I would ask the committee to consider adding the probate courts and my office as a person eligible to receive that information in the context of petitions for guardianship of the adult with an intellectual disability. We would certainly want to know in the probate court if there is a proposed guardian who has in fact had a substantiation of abuse or neglect, so that the court can evaluate the suitability of such a guardian. And I would just ask for that change. And I would be happy to answer any other questions.
Thank you. And your written testimonies do outline some of the recommended changes.
I have not specific language changes in my proposed testimony. I have shared it with the Department of Public Health, and I know we're working together to have some consensus perhaps to present to the committee.
Thank you so much. Seeing no questions, we appreciate your testimony. Thank you.
Very much for your time.
Thank you. And next, the person is Commissioner Deirdre Gifford. Welcome. Thank you, Dr. Gifford. Thank you for your patience being here.
Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claridis Ditria, distinguished members of the Public Health Committee. I'm Deirdre Gifford, Executive Director of the Office of Health Strategy, and I'm very happy to be here this afternoon to testify briefly in support of two OHS bills, SB 241 and 242. First of all, SB 241 is an act concerning the Office of Health Strategy's recommendations regarding the 340B program transparency. The goal of this legislation is to strengthen the 340B program and enhance drug affordability in Connecticut. Two brief pieces of context that I think I keep going back to as we work on our legislation this year. Connecticut in 2022, 46% of residents reported going without care or delaying care because of cost. 33% of our residents reported struggling to pay their healthcare related bills, including 12% that reported being contacted by a collection agency. In 2023, the Kaiser Family Foundation reported that 3 in 10 Americans that take prescription medication say they have not taken their medication as prescribed because of concerns about cost. So it's in that context that we offer this legislation and others in the governor's affordability agenda. A little bit of background on the 340B program, which is extremely complicated, and I will do my best to simplify it for those of you who may not be familiar. It's a program that was started in 1992 and requires drug manufacturers to provide outpatient drugs to certain eligible healthcare entities at reduced prices. The goal of the program, as stated in the federal legislation, is to enable those covered entities, that is the providers, to stretch scarce federal resources as far as possible to reach more eligible patients. 340B covered entities include federally qualified health centers, Ryan White clinics, some other types of publicly funded clinics, and hospitals, some hospitals. Recently, the 340B program has rapidly grown in size. There were almost $54 billion worth of covered outpatient drugs purchased through the 340B program in 2022. 340B entities can purchase covered drugs at the 340B so-called ceiling price. That is a deeply discounted price for the drugs. And there are some examples in some of the testimony that was submitted to you by others. That price is generally significantly lower than they would otherwise pay. In turn, those 340B entities are reimbursed by Medicare and commercial payers at the same price as they would be for other non-340B drugs. And this creates a differential or a margin that can be used by the 340B entity and which generates significant revenue. The savings under this program are intended to be spent to improve access and expand service, but the state has neither the insight into how much revenue is generated nor how it is used to stretch federal resources and benefit low-income populations. So this bill, of course, this being a federal program, makes no attempt to modify the underlying program. It's simply about transparency. We would ask the covered entities to report the total amount that they paid for 340B drugs and the total amount that they were reimbursed, in addition to how much was paid to contract pharmacies, if any, and the total number of claims for 340B drugs. This is a significant modification from the bill that we all worked on last session. Another slight difference is that we differentiate between federally qualified health centers and hospitals as covered entities, and would ask hospitals to report a little bit more detail on the 50 most frequently prescribed drugs under the 340B program.
Excuse me, Commissioner, but your time is over. Thank you.
Thank you very much. Let
But
me,
Commissioner, please continue because we have another bill that you're going to tell us about.
thank you, Senator. Senate Bill 242 is regards our all-payer claims database, and just briefly, it does 2 things. One is it clarifies the relationship between hospitals' requirement to report to OHS on their community benefit programs and the all-payer claims database. And the second thing is a request that OHS receive additional non-claims data into the APCD. Right now, hospitals are required under statute to report to OHS on their community benefit programs. There's language in the legislation that ties that report to access to the all-payer claims database, and we offer language that clarifies that hospitals would be required to make that community health benefit report with or without having data from the APCD, and also makes clear that the same data and privacy standards apply to hospitals as they do to all others who request data through the APCD. The second piece in this bill asks health insurers to submit data to OHS for the all-payer claims database. That includes some non-claims related data. So things like quality payments, bonus payments, and pharmacy rebates would also be requested to be entered into the APCD to give OHS the most comprehensive view possible of healthcare spending and costs in the state. Thank you very much. And of course, I'm happy to answer any of your questions.
Thank you so much. I think, Commissioner, if you could connect some of the dots for us, because the agency or Office of Health Strategy is asking for a lot of information from various healthcare facilities and hospital systems. Once you have the data, how is this going to be used? If you can help us understand that and connect that.
Senator, just to clarify, are you referring to the all-payer claims database, non-claims data, or to the 340B information?
Both of them, because there's, in other words, the Office of Health Strategies wants the 340B related data. You want all claims data. So I want to try to see, fast forward, we have that data. How is that going to help an average citizen in the state of Connecticut?
Yep, very good question. So let me start with the all-payer claims database. As you know, Senator, the office, we're very fortunate to have an APCD in Connecticut because it allows us to do a deep dive on many questions that are relevant to the residents of Connecticut. For example, we have used the APCD extensively as part of our healthcare benchmarking work to understand the drivers of increasing healthcare costs. So if you look at any of the slide presentations or reports that OHS has produced about what's driving healthcare cost increases in Connecticut, chances are that data came from our APCD. Right now, we want to continue to build that APCD. Right now, it includes fully insured claims as well as the state employee plan and the partnership plan, Medicaid, Medicare, and Medicare Advantage. We want to add to our ability to fully describe the spending and costs in Connecticut by having the non-claims information. So what is an example of non-claims information? If you're a physician that's working in Connecticut and you're part of a value-based contract and you receive let's just say a per member per month care management fee that's not related to a claim, that person coming to your office for a visit, but is part of a contractual arrangement you have with the health carrier, that is currently not reflected in the APCD because it's not a claim. But it's a significant part of our system. It helps us understand how much is being spent, for example, on primary care, and helps us understand what the drivers might be. So that's just one example of the type of non-claims data that what might help us really get a better understanding of costs. On the 340B side, Senator, this program is a very important program for both low-income residents of Connecticut and for the 340B covered entities. As I mentioned in my testimony, it generates significant revenue for both FQHCs and hospitals, and we understand that. The program has exploded in size in recent years, and it has not been, that explosion in size has not been accompanied by a new level of transparency about how the funds generated through that program are being spent. We know we live in an environment where people are struggling to afford their medications. We know that there is a lot of revenue related to this program. We don't know how one is related to the other. So the office would use this information to better understand how the covered entities are using their funds to help people afford their prescription medications.
Sure. I have a number of other questions, but I wanted my co-chair to ask a question to Representative Kristen McCarthy, and a number of other hands are raised as well. So we'll go through all of them. Representative.
Thank you very much, Mr. Chair, and thank you, Dr. Gifford, for being here with us today and for all of the good work you do to help us assure affordable, equal access to healthcare. My question is related to the 340B. You referenced in your testimony that this is different work than what we did last year. And sometimes we as legislators will say, well, didn't we do something on this last year? And if you could just compare and contrast a little bit what the conversation was last year versus this year and why it is important in your estimation that we go forward with this work this year as well.
Thank you, Representative. We did work on this together last session. The bill did not make it over the finish line. We were so close, but didn't quite get there. One thing that's the same, I'd like to emphasize, is that this bill makes no attempt to change the underlying 340B program. It's a federal program and it's implemented through the Health Resources and Services Administration. So that's something that's the same as last year's proposal. What's different is that there are some significant differences. One is there's a distinction between the reporting requirements for federally qualified health centers and those for hospital covered entities. The FQHCs would report under this proposal aggregate amounts as listed in my testimony, but not line items for specific drugs. Hospitals would be asked for a little bit of additional information, but less than in last year's bill. So last year was all entities reporting all the drugs that they purchased through 340B. We've scaled that back significantly. No individual drug reporting for FQs, top 50 drugs by volume for the hospital covered entities. And in both cases, we'd like to also have reported a description of how the revenue being generated through the program is being used to benefit low-income populations.
Dr. Gifford, thank you for that clarification. And I think that's helpful for members. And I think that last point of emphasis, which is about how these funds are being used to directly benefit our most vulnerable residents, is really helpful. So I know there are other questions, as Senator Anwar said, and I know that we will continue in conversation throughout this session. Thank you so much. Thank you, Mr. Chair.
Thank you, Representative Denning, followed by Senator Gordon. Rep. Denning.
Thank you. Thank you, Mr. Chair. Dr. Gifford, thank you for coming and testifying. I also have some questions about the all payers claim database. So right now we can collect that data for what the claims are. Do we also collect the data right now for what was being paid on those claims? And to go ahead and include extra payments, how would that be registered as far as the claims that were being made to, let's say if they're making additional payments to physicians, how would that be contributed back to a particular patient and or service? I'm just a little confused about this data that you're collecting.
Thank you for that. With respect to the first question, yes, allowed amounts are in the all payer claims database. So we have both what's paid by the carrier and what's paid by the patient, if there's a copay for the claim. So yes, the financial information is in there and it's critical for a lot of our work. With respect to your second question, I think the linkage between a particular patient and the non-claims information would depend on the type of non-claims information we were collecting. In many cases, it would not be directly linked to a patient. For example, the example I gave to the senator about a quality bonus payment or a per member per month care management payment would be in a more general category of payment, not linked to a specific service or to a specific patient. That's why we're adding it as an important data source that gives us the full picture of spending on healthcare.
Thank you very much. I appreciate you wanting to know the additional data. My concern is how do you effectively use that information other than to have a gross total amount to know how that money was actually attributed to the care that was provided? And that's my only concern. But thank you for your time. And thank you, Mr. Chair.
Thank you, Senator Gordon.
Thank you, Mr. Chairman, and Dr. Gifford, it's nice to see you. I'm only going to be able to ask a few questions, so I'll send a separate letter that we'll have lots more questions. I'm very, very familiar with the 340B, having been in the trenches for many years in roles I've had chairing pharmacy and therapeutic committees at various hospitals. So I understand the program, and it is a federally regulated program. It's not a program that's directly emanating from the state of Connecticut. It's a federally regulated program, as you testified, and that's a very, very important point. It's also a highly regulated program. It's not as if any entity, be it a hospital, and we do have a number here in the state that participate, or a qualified community health center, and we do have those here in the state, can just enter with the snap of a finger. There's quite a bit to be considered for it and to maintain staying within it through the federal government, not the state of Connecticut necessarily. And I think that's very, very important. And I do want to highlight that you did testify that it is a federal program, as we all know. But one of the questions I have that I'll ask is, in your testimony, you do state that you had conversations with stakeholders, yet interestingly, the testimony we have from the Connecticut Hospital Association, the Community Health Center Association, and
I actually more strongly about getting.
And 7 hospital systems across the state all raise serious concerns and questions about what you're proposing. So I think that's one of the questions I'll separately ask you another time, is what actual stakeholders did you have conversations with? Because it seems if you did, they're not really that supportive of what's being proposed. But you do mention in your testimony, I think this is very important, that you state that this proposal is modeled after a similar 340B transparency bill that passed in Minnesota only last year. So my question to you is, if you're going to model something on a state that passed this in 2023, how is that working in that state of Minnesota before we decide to march down that road? And how are all the stakeholders handling whatever is the information requests, some of which they clearly and rightly say are impractical and difficult to get based upon the parameters of the federal program? Again, administered by the federal government initially. So I'm interested in, how is it working in Minnesota if this is modeled on the Minnesota law?
Thank you, Senator. With respect to the federal nature of this program, the HRSA, the Health Resources and Services Administration that oversees this program, does not provide the information that we are requesting in this proposal. It's why a number of states, Maine, Minnesota, I believe Rhode Island, Connecticut, are, you might say, stepping into the breach because HRSA has not made transparent the level of revenue that's being generated through this program. So although there is some reporting, I think the testimony reflects that what has to be done annually with HRSA is to reapply to participate in the program, but there's nothing in the testimony that suggests that this level of information about revenue generated is currently being reported to HRSA. With respect to stakeholders, I would say there are many stakeholders here around drug affordability, and not just those that you mentioned. And we take their input seriously as well. With respect to Minnesota, of course, it's early days in that program. We mentioned that bill just to say that as I said, there are a number of states that are looking at the 340B program precisely because the Health Resources and Services Administration has, for whatever reason, chosen not to make available this level of information.
No, thank you. But my question was actually, if I may, Mr. Chairman, how is it working in Minnesota? Because you specifically state you modeled it after Minnesota. And I'm all for transparency when it's realistic and responsible and reasonable. But again, if it's modeled after Minnesota, how is it working in Minnesota? If you've modeled your proposal on Minnesota as your testimony directly states.
So I would say Connecticut, Maine, Minnesota, a number of other states are leading in this area, and many states are looking at our work for ideas about how they may get further transparency into the 340B program. As I mentioned, Senator, it's early days in Minnesota, and it's too soon to say how the program is working there.
And thank you for that. I think that actually supports my point. If we're going to model something on Minnesota and it's too early to know how it's working or not working, that should be a caution flag, because this is a lot of information, as you know, for hospital systems to dig into and get. That may not be required by federal oversight, but it is a lot of information. I think we do need to listen very carefully to what the folks in the trenches are saying about their concerns before we start marching down this road, separate from how this data may or may not be used, which is a separate concern. But we do need to be very, very careful about that. And their concerns are legitimate, understanding the detail that you're asking beyond what they're already required to provide. So my next question would be, are you planning to follow up with all of these stakeholders who have raised concerns? And again, they've raised some serious concerns and questions to address their concerns and discuss the concerns with them.
As always, we're in regular contact with our colleagues in the hospital and FQHC communities, and we'll continue to talk to them about the concerns here. I will note that the American Hospital Association has proposed a structure for reporting on 340B revenue generated, as well as a structure for reporting on how those revenues are being used. So the hospital industry itself has recognized the importance of this reporting and has put out a framework to do so. Of course, Senator, in answer to your question, we'll continue to talk to the stakeholders.
Thank you, Mr. Chairman. I just want to mention there's a difference between the American Hospital Association and those entities here on the ground in Connecticut. And I know you know that difference, but I look forward to asking more of these granular questions to you at a different time. Thank you, Mr. Chairman.
Thank you. Dr. Gifford, can I just also clarify a couple of things? So along the same lines, there are 5 hospitals, smaller hospitals that are in very significant financial difficulty, to the point that the state is helping some of them to be able to survive. And if we were to put some regulations to have more information, more data collection on them, is it going to have a detrimental impact on the healthcare systems that are struggling?
Of course, Senator, we are cognizant of the striking the balance between the important public interest in this type of information and the administrative burden on the industry. So of course, we would want to work with stakeholders to make sure that the reporting was easily understood and as easy as possible to produce. I'm getting a little bit of confusing messages because on the one hand, we're being told we're already doing this reporting, and on the other hand, we're being told it's too burdensome to produce the reporting. So I think the truth is likely somewhere in the middle there. We would want this is a minimal level of data items. As I mentioned to Representative McCarthy-Vahey, we significantly scaled back from the proposal from last session. And this more closely aligns with the AHA framework that I mentioned earlier that we had discussed with stakeholders last session. So in answer to your question, Senator, of course, we want to be cognizant, and OHS, in fact, as we speak, is working with a number of hospitals on extending deadlines, for example, for some of our financial reporting. We will always do that and want to make sure that any reporting is as minimally burdensome as possible.
So if I heard you correct, you're saying that most of this information is already being shared by the federal government as a part of the federal program. So it's just sharing the same information with the state.
The information on the delta between the price that's paid by the covered entities and the amount that's reimbursed is not available through the federal program. That's the reason why states are proposing this legislation. States are in the situation of trying to help their residents afford prescription medications. We know that this revenue stream exists, which is designed to assist low-income populations with purchasing prescription drugs, and yet the states have no visibility into how that revenue is being used. So there is some reporting, but this reporting is not happening and it's not available to states.
And the other question, and I say this quite a few times, so I'll just say it again. When the cost of healthcare is an issue, and it's an important issue, we have to collectively address that. If the cost of healthcare is going up, the cost of insurance is going up exponentially much more than the cost of healthcare. And when at times around this conversation that we have, we are always trying to figure out a way to clamp down on the cost of healthcare. And that impacts some of the smaller entities much more than larger entities, but it's going to impact the larger entities too. But the cost to the consumer is the ones who have insurance or underinsurance, because everybody's underinsured because you have to figure out a way to pay out of pocket. But when you look at the losses that the healthcare systems are incurring, they're in hundreds of millions of dollars. But when you're looking at the financial benefits that the insurance industry is having, they're in billions of dollars of financial benefits. So one is losing millions and other is making billions. And in all of our effort at times seems that we are focused more on the healthcare systems, but the consumer is getting killed by the premiums and the deductibles and the copays as well. Just want to put that out there, as that should be a focus too.
Senator, I think you make a very good point, maybe inadvertently, in support of this 340B legislation, because it's precisely the individual who may not be able to afford her medication may be getting that medication through a 340B covered entity, but is not benefiting directly from the discount that the entity receives. And that's one of so just to be clear, there may be patients who receive a prescription from a 340B covered entity, but that don't pay the discounted price at the pharmacy counter. And I think that's a really important question that we all need to understand better. How is that spread, that margin, benefiting that person at the point of sale? Exactly to your point about affordability, Senator.
Thank you. I'm sure we'll have a number of conversations around this to figure out these areas. I see no other question. We have one more question from Senator Gordon.
I'll be
Did
real
you say
quick.
how I said one more question?
But you didn't say I couldn't ask a question in compound parts. But I'll ask just one quick question. Thank you, Mr. Chairman, for indulging me. And thank you, Dr. Gifford, for answering the question. When you talk about trying to understand revenue and you're talking about HRSA with regards to its oversight or not oversight, and there's quite heavy oversight, I believe, by the feds on a number of issues for this program. Again, it's a federal program. There's also reporting to the IRS, which certainly can do its own audits, as can HRSA, and HRSA does do audits. And I've lived through a HRSA audit at one of my hospitals. So when you talk about revenue and bad debt and many other things, there is also reporting mechanisms to the federal government that are required through a massive agency. That's the IRS. So I think we do need to be careful. And my question is, with all this reporting that's happening anyway, and these hospital systems are enrolled in the program, have the oversight by the federal government, what exactly will OHS, how is this data helping OHS? Because all the data that I've seen OHS collect to date, I haven't really seen what it actually is doing. And I agree with you that there is a certain degree of transparency, which is the federal government does running this program, but also with regards to trying to achieve certain goals of getting medications and treatments to low-income people, especially in disproportionately served areas, which is an underpinning of the 340B program, which is important. What exactly are you going to do with the volumes of data that you're going to require the hospitals to use resources, money, and personnel? I'm just a little confused because it just seems that you're going to be getting more data, but I haven't heard specifically, what are you going to do with the data? And I'm happy to ask those specific questions in my pages of a letter to you, but I'm just trying to understand more than a generality. If we're going to put them through the ringer for all this data, a lot of which the feds do ask for, and I think we can disagree or agree to disagree about that. What are you going to do with all of this data specifically in what time frame? Thank you, Mr. Chairman.
So can I suggest something? There's a lot of questions and perhaps we can do a follow-up meeting on this conversation. Is that okay?
Happy to.
Okay. Representative Zupkus, you have a question too.
I do. Thank
First
you,
time.
Mr. Chair. Thank you for coming, Dr. Gifford. I have a question. We're talking about the cost of healthcare and hospitals understaffed and all these pressures. And my question to you is about the CON process. And number one, Waterbury is struggling and that hospital could go out if it doesn't happen. So I have a question. Do you have any idea when the CON is going to be confirmed? And my second question is, that has been a process that has been a struggle for years. We actually passed a law last year for a birthing center to circumvent the CON process because it's such a cumbersome process. So I know that this is a bill that's going to be coming up. So do you have suggestions? Should we do away with the CON? What should happen with that to make it fair for everybody and a better process? And Waterbury.
Thank you for the question. There are two bills that contain significant modifications to the CON program, and I look forward to testifying on both of those in the future, and happy to meet separately to talk in as much detail as you'd like about the CON program. We look forward to, Senator and I have had some conversations in between sessions, and look forward to more engagement on that very important question. We certainly understand. With respect to the Yale Prospect CON application, as is been made public, the state has been in settlement negotiations with the parties for some time now. We are meeting regularly and making good progress. So we anticipate that there will be some additional news to report. Those are confidential settlement negotiations, so I'm not at liberty to talk about the content in detail. My office did present a settlement offer on October 20th to the parties, and we've been having conversations since that time.
Thank you. I hope it's going to be soon because it can't last much longer. And number one, and number two, I know that is probably the longest CON process, I think maybe ever. It's been over 4 years, if I'm not mistaken. So it's just concerning. And it's very concerning for the citizens of Waterbury, the underserved who use that hospital. And all of the.
So what I will do is I'll just make a quick comment. We have two bills that are going to be coming up in a public hearing on this very topic. One of them is from the Public Health Committee and one is Office of Health Strategies. And so we will have a lot of CON conversation in the coming weeks. So, but
Senator, if I could, the
Yes.
application in this matter was submitted to the Office of Health Strategy in November of 2022. And in October of 2023, a draft agreed settlement was presented to the party. So there may be another application you're referring to with that duration, but it's not this one.
Great. Thank you. And I look forward to that happening. Thank you.
Thank you so much, Dr. Gifford, for your testimony. We appreciate you being here. Thank you. It's been over more than an hour. We had a number of our agency representatives who had been speaking. We wanted to alternate between public and agency. So we have crossed that threshold actually a little while ago, but because the testimonies went for a little longer than expected, we will start to alternate between public and our agency representatives and commissioners. So the next person is I'm going to jump from 4 to number 9, Jonathan Green. Mr. Green is probably on remote. If you want to see if we can elevate him. Yes, Mr. Green, welcome. Thank you for your patience. Welcome. Go ahead.
Good afternoon. Thank you. Thank you, Senator Anwar, Representative McCarthy-Vahey, Senator Kushner, Senator Marks, Representative Parker, Senator Summers, Representative Clarides Ditria, and distinguished members of the Public Health Committee. My name is Jonathan Green. I'm a licensed funeral director, embalmer, and the legislative chair of the Connecticut Funeral Directors Association. We are one of the oldest and nationally recognized associations of funeral homes in the country with over 220 funeral homes. Thank you for raising HB 5290. The CFDA supports this bill, which addresses and expands the definition of cremation to include alkaline hydrolysis in sections 10, 11, 12, and 13. Alkaline hydrolysis is an emerging form of flameless cremation already available in about half of the United States. Unlike incineration, alkaline hydrolysis uses a combination of water, alkaline chemicals, heat, pressure, and agitation to accelerate decomposition of a body in a specialized chamber. Alkaline hydrolysis uses less fuel and has less of a carbon footprint than flame-based cremation. This may appeal to consumers who are desiring of a greener choice at a more reasonable cost than that of traditional funeral services. CFDA further supports this bill, aligning requirements for alkaline hydrolysis performance by a crematory with the same licensing procedures, inspections, permits, medical examiner approval, and 48-hour waiting period, all already required for cremation by incineration. We stress that due to the direct handling of human remains without any barriers, such as a pouch or an alternative container, that the performance of alkaline hydrolysis should be on the grounds of a funeral home for both public health and safety reasons. Thank you very much for this opportunity to testify, and I'm certainly available to address any questions or comments you may have.
Thank you so much for your testimony, and we appreciate the fact that you like the changes that the Department of Public Health has recommended on this topic. So seeing no questions or comments, we will move to the next person on our list. I think number 5 was part of the Office of Health Strategy, so we'll go to number 6, Commissioner Jordan Sheff. Welcome, Commissioner. Thank you for being here.
Hello, Senator Anwar. Good to see you, and thank you for having me.
Good to see you.
It's been a long week for many of us. I'll do my best to summarize my testimony and be brief and be prepared to answer questions. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Clarides Ditria, and members of the Public Health Committee. I'm Jordan Sheff. I'm the Commissioner at the Department of Developmental Services. Thank you for the opportunity to testify on House Bills 5292 and 5293, and thank you for raising the department's bills. House Bill 5292 closes a gap in safety by allowing DDS to share information on substantiated abuse and neglect cases that took place in a community companion home, we refer to as CCHs, resulting in license, surrender, or revocation. This bill would allow the department to share the findings with sister state agencies and qualified providers so that they can make educated decisions when hiring former licensees. We currently have this process in place for direct care workers, but not for CCH licensees. House Bill 5293 proposes several technical changes, and I'll briefly summarize each. Sections 1 and 2 would recognize the DDS dental programs, long in operation, would recognize them in statute and allow for provisionally licensed dentists to practice in our offices. This would allow the state to better support the more than 2,000 individuals with intellectual disability who are served at our dental programs annually and prevent and eliminate gaps that we've experienced in the past of service provision. Section 3 makes revision to House Bill 5001 to transfer the supportive housing grant program from DDS to Department of Housing. We already partner with the Department of Housing on many supportive housing projects, but they have the infrastructure and processes in place to manage these grants, and we do not. Sections 4, 5, and 6 would remove the cap on the number of self-advocate coordinators that the department can hire. This would allow us to better navigate and integrate the voices of our self-advocates into all areas of our business. Sections 7 and 8 would update the statute regarding transfer of individuals receiving support and services from the department. Importantly, it would add a process for temporary transfer due to public health or safety emergencies. Sections 9, 10, and 11 would make technical adjustments to recognize the department's human rights and program review committees, referred to as HRC and PRC, in statute, which would allow us to move forward with revisions to the regulations and policies / procedures governing them. Section 12 would add the Office of Labor Relations to the list of agencies that have access to the department's abuse and neglect registry. This will allow them to appropriately handle personnel matters on behalf of the department when a state employee has been placed on the registry based on substantiated abuse or neglect. Sections 13 and 14 would recognize the DDS ombudsperson in statute and ensure proper notification to the ombudsperson and DDS when an intermediate care facility is closing. Thank you for the opportunity to offer testimony regarding the department's bills, and I'm happy to take any questions you may have today.
Thank you so much, Commissioner. Commissioner, I don't know if you had a chance or one of your staff may have had a chance to listen to the testimony from Office of Child Advocate, Ms. Egan earlier.
I was at our appropriations work group meeting immediately prior to this. But I did have staff in the room, and I had the opportunity to speak to Sarah Egan yesterday and on many other occasions recently.
So one of the things that we were talking about was for 5293 to see if there's an opportunity to have some improvements specifically with respect to the December Office of Inspector General's report. And as this bill is moving in the right direction to address some of the issues, there's probably opportunity to do even more. So are you open to having conversations to make sure that the risk of abuse and safety of the DDS clients is going to be could be strengthened with some of the other recommendations?
I'm always open to conversation, Senator. There is a lot that has happened during and subsequent to the OIG report and work that is ongoing and recognized by the Office of the Inspector General and the Health and Human Services that suggests we've largely met the requirements from that report. I don't begin to suggest that we've eliminated all the issues and certainly the issues that the Office of Child Advocate has raised. Whether or not those things need to be codified in statute or law, given the progress we've made currently and the collegial work that we do together, I'm certainly open to the conversation. I'm not certain that the legislature needs to be part of that, but I'm open to having that conversation.
Sure. We want to be in the picture because we represent these individuals, and so you can try, but you won't get rid of us.
Oh, I'm not looking to get rid of you. I just think you have a lot on your plate, and we're already doing the good work of those same people. Yeah. The 17,000 eligible individuals for the department are near and dear to me, as you know.
Yes.
I wear my emotions on my shirt sleeve. Many of you around the table have had private conversations with me about the work we do, and I understand you want to codify things. Were the day to come that I was no longer sitting in the seat that I am, so that the good work that the department has done under my leadership will continue. So I appreciate that. And I'm open to discussing what you might look to consider codifying in law that isn't already subject to federal oversight.
Sure. And again, I can tell you because we have shared a few of the clients and how committed the staff have been and then how sometimes a challenging situation it is. We appreciate your work and the staff and the team's work. But I also recognize that sometimes you have DDS employed individuals, they're at a different frequency and they're doing very well. But when there are group homes or and facilities where some of the clients are living, which are independent and separate, they're having workforce issues. Mm-hmm. And they're very real workforce issues and that is resulting in the well-being of our children and adults who are in these facilities. So we need to figure out how can we pay them reasonable amount that people can make a career out of providing that hands-on direct care. And then we are not seeing that right now. And that's part of the difficulty that we are hearing from our communities. And we want to see how we can address that because the most vulnerable at times are not the loudest voices. And then when there's money that comes in, we feel that they may not necessarily be heard as well. And we want to make sure there's protections for them. That's the whole idea.
Thank you, Senator.
Want to say anything about it?
Well, I'm not, so I've talked a lot about this week, and I'm not sure which committee wants to be in charge of generating laws that are going to help me develop the workforce beyond the work that we're already doing. I'm happy to talk to anybody who would like to help me bring more people to the workforce that we do, and wherever that language needs to be, whether that's before Public Health, Human Services, or Appropriations, I'm happy to work with any and all of you to improve what we're doing in attracting people to the workforce.
The issue is that if you're not giving them living wage, you're never going to get the workforce. How do we figure that out?
So I'm happy to have that conversation. I'm not sure what you would like me to say beyond that. I
Okay.
came today to talk about some technical issues in the bill and hope to provide dental services to people and to help support the good work of the Office of Child Advocate to improve our system so that we can better assure bad outcomes don't happen to people. And that's what I was prepared to talk about today. I did talk to the working group about these same issues for the last hour and change on what we would do about workforce things. And if you would like to talk further about that, tell me who you would like me to talk to and who you'd like me to engage with. And I am happy, as always, to try and improve the system.
Thank you. I see my co-chair has a question or a comment, so I'm going to have my co-chair ask a question.
Thank you.
Thank you very much, Mr. Chair. And Commissioner, thank you for being here with us and with so many other committees. There is definitely a lot of interest in the work that you're doing, and we're grateful for that. Earlier, again, your staff may have been in the room, but we heard from the probate court about their desire to also be notified and aware. And I'm wondering if that's something, if you would object to their inclusion, or if there was a thought about why they weren't included initially. If you could just shed light on that, that would be wonderful.
Included in what? I'm sorry, I couldn't hear you over the Zoom. What was? Hi, Judge. What didn't we include the Office of Probate in?
In the notification, the sharing of information between agencies.
So the Office of Probate, we meet with the Office of Probate and Judge Beverly quarterly. And so this issue that we're not sharing, are they looking to be included? Can she join me during, I don't know the protocol, and I'm not.
Sure. You know what, Commissioner, maybe I'll just put it this way. If you and that's wonderful to just for all of us to hear that you all have regular conversations, and just would invite you to continue those offline to make sure that all the appropriate and available parties are sharing information. And thank you for your time. Thank you, Mr. Chair.
Thank you.
Thank you. There's a lot of work to be done.
Sure.
And then we will help you in that process. And thank you for everyone that does. I just want to make a quick little statement. One of the agencies that has a very difficult and very challenging job is your agency. If somebody is being taken care of for 365 days and of those 364 went well, but the 365th did not, we all hear about it. And our hope is that all 365 days would be good, because the value of a society is judged by how we treat the most vulnerable. And from what I've heard from other people from other states, we do a far better job than most other states do. But Connecticut, we don't compete with anybody, we compete with ourselves. So that's where we see that there's an area of opportunity, and then there are workforce challenges that we clearly know of, and see that there's a transition. Individuals can perhaps make more money at a Walmart or other places, and then that's part of the challenge when they would not like to do the difficult work that they're doing, and we are losing the qualified individuals, and as a result, our clients, our community, our constituents are suffering. So we will have to figure out, and I think we are trying to figure out legislatively if there's things that we can do.
So I thank you for that. And I will let me share a couple things responsive to the workforce initiative questions that you're raising, unrelated to the bills I thought I was talking about when I walked in, that I was prepped for. I took the approach during the conversations around House Bill 5001 that looked to ameliorate concerns within our community last year, to work with the governor's office and bring on a person to my staff at a high level with many years of service in the private sector, who understands the nature of the private sector world and the nature of the business that we do. And after many years in private sector service, she's come to work in public solely under the responsibility. The task before her is to help us work both at the state level and the regions within the state. And then she's on working with our partners nationally to identify strategies that'll help improve this workforce crisis, which is not germane to Connecticut. It is national. And we are doing better than other states during this workforce crisis. And as you said, we don't compete with other states, but you noted that we lead in many areas. And I appreciate that recognition. I would say in most categories of measurement for IDD systems, we are in the top 4 or 5 in the nation in most categories, competing with the great states of California and New York, and our partners in Tennessee and Louisiana, which are not normally thought of as progressive states, do phenomenal work, and we work collegially with them to identify what they're doing where we can make improvements. So we take a big picture, but we do want to make Connecticut not just in the top 5. We want to be the #1 in all areas in our book of business, and improving the conditions of our workforce will help us in those strides. So I appreciate that intent.
Thank you. Seeing no other questions or comments, we want to thank you for being here and your testimony.
Okay, thank you.
Thank you. All right, the next person on our list is on number 10, Thomas Tierney. Welcome. Thank you for being here today. Welcome.
Senator Arnoir, Representative McCarthy Vahey, Senator Summers, Representative Clarice Ditria, and distinguished members of the Public Health Committee. My name is Thomas J. Tierney, and since April of 2020, I've owned and operated the John F. Tierney Funeral Home in Manchester, and have recently established Connecticut Aquamation in Manchester. A third-generation funeral director, I'm extraordinarily blessed and grateful for the opportunity my parents and grandparents have afforded me in the funeral industry. Taking care of the deceased and their loved ones is something I'm extraordinarily passionate about, and improving memorial options in an environmentally conscious manner is a tremendous opportunity for the deceased, those they leave, and generations to come. As owner and operator of one of, or the first, alkaline hydrolysis system in the state of Connecticut, I appear before you today in full support of House Bill 5290 as regards to alkaline hydrolysis. My 21 years of experience as a licensed funeral director in the state of Connecticut, I've experienced tremendous change in the families we are fortunate enough to serve. The growth of cremation is undeniable, and alkaline hydrolysis provides an opportunity for the consumer to select an environmentally friendly form of cremation. Treating this form of disposition with the same regulation as incineration or fire cremation maintains consistency in this final disposition, reducing the body to what is commonly referred to as ashes. It provides the checks and balances necessary for such an important process. Also, because of the nature of the alkaline hydrolysis process, requiring it to occur on the grounds of a funeral home will ensure that licensed professionals in a licensed establishment are overseeing the process with the physical deceased human remains. We wish to thank the Department of Public Health and the committee for their careful consideration regarding alkaline hydrolysis. Thank you.
Thank you so much for your testimony. Thank you for your support of the regulations, and thank you for the work that your family and you have been doing for such a long time in our communities. We appreciate you. No questions or comments. We appreciate you. Thank you.
Thank you.
Next person on our list is Commissioner. My God, you just appeared. I blinked and you appeared. Welcome, Commissioner Navarrete.
Good afternoon, Senator Arnoir, Representative McCarthy Vahey, Senator Summers, and Representative Claritas I could never get that name right, Ditria, and distinguished members of the Public Health Committee. Thank you for the opportunity to provide testimony on SB 243, an act establishing an ACT pilot program for home health agencies. I think you all know me. I'm Nancy Navarrete, Commissioner of the Department of Mental Health and Addiction Services. You have my written testimony in front of you. I believe you are familiar with the mission of the department. We serve individuals with complex behavioral health disorders who would not otherwise have access to treatment services. So if I may, I will start by detailing what the ACT level of care looks like and who it serves. So it is a successful evidence-based intervention serving approximately 500 of the most complex and disenfranchised individuals in the state. So we serve annually the department as a whole, about 100,000 people in the department. And of these are the most disenfranchised people that we serve. So the program tries to build and establish trust, perhaps over the course of months or years, with a multidisciplinary team. So that team is made up of doctors, nurses, clinicians, and peers, geared to meeting people in the community in shelters, under bridges, in soup kitchens, and other settings where they may be vulnerable to victimization, isolation, and lack of assessment of their needs. So I just wanted to remind folks that individuals with SMI, serious mental illness, are no more violent than the general population. So when individuals are stigmatized or feel rejected by mainstream healthcare, our teams reach out and try to build those connections. Unlike typical outpatient clinics or case management programs, the ACT ratio is 1:10 staff to clients. We have 10 teams statewide, which is meeting the current need. The service is well utilized and very targeted in who is receiving those intensive services. Individuals may or may not be receiving additional community nursing services. These ACT teams are adept at collaboration and might communicate daily with service providers as applicable regarding somebody's mental health status. Research has shown positive outcomes such as reduced hospital stays, improved housing stability, and increased quality of life. So we would agree with you that these ACT teams are valuable and they play a very specific role in our system. We feel that an embedded model within the home healthcare agencies in this case would be duplicative of services and most likely strain an already depleted workforce of behavioral health providers. We would encourage home healthcare collaboration with both our PMP and state-operated local mental health authorities in the case of shared clients, and we're very happy to have additional conversations around strengthening these relationships. We're willing to provide education and subject matter expertise regarding SMI and recovery-oriented, non-stigmatizing ways to engage individuals into trusting and supportive connections. In its current form, the bill would have direct service providers playing a protective role and function to another agency, which is outside the scope of their role, and again, not the best use of such highly valued interventionists. So I am grateful for your support of individuals living with behavioral health disorders and hope that we can have additional conversations around our policy concerns and implications of the unbudgeted fiscal impact to the agency. Happy to take questions.
Thank you so much, Commissioner. You're talking about Bill 243, right? The concept behind this whole thing is it's part of home care worker protection. And this is a pilot that we are trying to look at as a policy. There is, you know this very well, there are ups and downs in the health and the well-being of individuals who are going through various struggles, whether it's substance-related or mental health. The safety net is not working as well. Let me rephrase that. The safety net is not working perfectly. It's working, but it can improve. And with the death of one of the nurses, we feel that there's an opportunity to try and look at this in a manner where we create a pilot of the communication and escalation of the support. So it does not automatically mean that everybody needs to go to the hospital. It means that we need to have a system where the home care worker who's visiting can see the signs and would be able to escalate it to the next level, and then have the ACT team be on board to help coordinate the next steps and then create clinical interventions if needed. So that's the perspective.
Right. So I understand that. So right now, these are clinical teams and they have caseloads of their, as I said, the ratio is about 1:10 staff to clients. We serve about 500 clients of the total clients we serve in the state, which is about 100,000 clients altogether. So currently our teams do coordinate, and happy to have additional conversations offline about how to improve relationships. We feel like those relationships are good. Sometimes people are using home health agencies that we're serving, and sometimes they're not. So sometimes the folks that we're reaching out to are not even at the point where they're willing to take medications are willing to have a nurse come into their home. And the process that we are doing over the course of many months or even many years is try to develop that trust with the individual. And then that team would meet daily, and if a provider were involved, like a home health agency, then we would call that provider if there were a change in that person's mental status, for example, or physical health for that matter.
So, and then that's the crux of the issue that we're looking at, is that and we had heard from, and then we'll probably hear today from individuals in home health services that are claiming that when they're asking for help, they're not getting the help. And the answer is not to go to the emergency room, because the emergency rooms have no room and the hospitals have no room. And an early intervention will keep people in the home environment, which is the safest place to do, to manage them for the most part. I think that's where the opportunity is, to have that collaboration and then creating intensive coordination and creating a mechanism that we reduce the probability of bad things happening. And I think that's the whole purpose for this pilot study we are exploring.
So, like I said, we'd be happy to talk more about how to strengthen those relationships and what our concerns around the policy are. We don't feel like the best model would be to embed our teams, which is serving this small cohort of people, into a home health agency that may be serving a much larger cohort.
So how do you think things could get better?
I think it would be a matter of the home health agencies connecting with our local mental health authorities. So it's our local mental health authorities that are hosting these ACT teams and have the resources to do some of the case management and outreach to the most seriously disabled individuals.
And where do the mobile crisis units fit into this?
So anyone can call mobile crisis at any time, calling 988 or our action line, and we would assess whether someone needed to be deployed into the community or not. Sometimes things can be resolved on the phone. Sometimes it involves an in-person call or someone going into someone's home to do a wellness check. Okay.
We'll hear from a number of other individuals today. I think the next person who's speaking is one of the home health agencies CEO, who's brought some of this in a conversation when we had a whole session on protection of health home care workers. So we'll listen to what others have to say and see what are the areas of opportunity to find common ground and work on some of this.
Sure. Like I said, we're happy to collaborate. I don't see it as the role of the existing ACT teams to play a protective role in another agency, but we are content experts and we're happy to help in any way that we can.
Can I clarify that?
Sure.
So that's part of the challenge sometimes we have. When you say an agency is a home health agency, but the ACT teams are working with DMIS.
Correct.
And the home health agencies are working with DPH or answerable to DPH, if you will.
If they're licensed, yes, I guess DPH would license.
So the patient who could be a danger to themselves or somebody else needs to be taken care of. And we are trying to figure out how can we make sure that the home care worker is protected and the patient is protected. And we know that the existing system has some weaknesses. So I'm not fully comfortable with the idea that it's a different agency and we should probably silo that out somehow. We want to try to address that issue. So that's my...
We would play a protective role with the client, but not with another agency's staff. So we're happy to coordinate care, and we do coordinate care around the individual.
Okay. And this is what the pilot is about: coordination, close coordination of care. Okay. Thank you so much.
You're welcome.
Oh, wait. Commissioner, one more question. Sorry.
Thank you, Mr. Chair. Thank you, Commissioner. I was just going to sort of follow up on that and maybe open it up a little bit for you. Given the sense that there's a concern here coming from healthcare worker safety. Do you have any ideas about what you've seen in the system that we could also be addressing to further support safety of these folks that are going out and doing this important work in the community?
Sure. We put a lot of things in place, things that we've had over time because this is the population that we work with, specialized risk assessments, ways to communicate with and between our staff members and other entities. We're happy again to consult in terms of operational processes that can be put in place with other agencies that would mirror some of the things that we do in our agency. It's about constant communication, assessment. We're able to do case conferences with our medical staff. And because this team has such a low client staff ratio, we're able to triage that on a daily basis if we need to. Somebody could, the team could alert the entire treatment team if someone is decompensating, or if there's an additional risk of substance use, or if there's some intimate partner violence going on in the home. Those are all things that the team would be in regular communication about and can either heighten that alert or notify folks when the person is stabilized.
So thank you for that. Is it your sense that the staff then in the system you've got set up currently are protected and well supported, and you feel like there's a good system in place that maybe should be further modeled? And sort of related to that, is it your sense that the capacity is not an issue either? There are enough of these ACT teams to serve the clients across the state?
Yes, for the folks that meet the criteria for these teams, we do have coverage and slots available to accept new patients.
Thank you so much, Commissioner. Thank you, Mr. Chair.
Thank you, Commissioner. Thank you for your time today. Next person on our list is number 11, Sasa Harriet. Welcome, Ms. Harriet.
Good afternoon. Can you hear me okay?
Very well.
Awesome. Good afternoon, Representative McCarthy, Vehi, Senator Anwar, ranking members and esteemed members of the Public Health Committee. My name is Sasa Harriet, and I am the President and CEO of Harriet Home Health Services, a Joint Commission accredited state licensed home care agency. I am also a board certified psychiatric mental health nurse practitioner. I come before you today to testify in support of Senate Bill 243, an act establishing an assertive community treatment team pilot program for home health care agencies. Our agency, Harriet Home Health Services, is based in Hartford and serves patients across Connecticut. We go where others won't, treating patients in high crime and high risk areas. Our agency provides a range of services, including physical and behavioral health services, along with comprehensive support services, including violence intervention. My goal today is to emphasize the critical importance of assertive community treatment teams in addressing the complex needs of individuals with serious mental illnesses and co-occurring substance use disorders. This is particularly important in the context of systematic healthcare inequities, long-standing stigma around mental health, and the ongoing epidemic of gun violence in the communities that we service prevent and reduce others and local ACT teams from being willing to service the clients in our neighborhoods. This is an epidemic that impacts everyone, but especially those in high-risk areas where violence can decrease a patient's access to high-quality healthcare providers, resulting in people being harmed. According to SAMHSA, assertive community treatment is an evidence-based delivery model of care that provides community-based rapid response home care services for individuals with serious mental illness who are at risk for various crises, including hospitalization, homelessness, and involvement in the criminal justice system. ACT teams provide critical support for home health care workers for patients with complex behavioral health needs who require a multidisciplinary team to provide the care that they need. These teams are especially important when treating patients who live in areas affected by gun violence, like the Promise Zone in the north end of Hartford. They provide the necessary psychiatric care along with acting as a form of backup for the primary home health care worker, families, and the patients that are unable to reach other providers in the community. There are currently statewide ACT teams who we call on when we are treating these high-risk and complex needs patients. However,
Ms. Harriet, your time is up. Thank you.
Actually, please complete your testimony.
thank you. However, due to a lack of resources, it can take anywhere from days to months for a patient to be enrolled in the local mental health authorities who would then contact an ACT team. When treating high-risk patients, a delay in care can have significant consequences, including suicides, medication overdoses, and preventable harm to self and others. Home health care workers need to be able to provide immediate and rapid care to their patients. Senate Bill 243 will enhance the capabilities of home care nurses in managing high-risk patients and ensure the safety for both the home health care workers and our patients through improved operational efficiency. To conclude, by integrating the ACT team within home health care agencies, this program will bridge the gaps that traditional home health care and specialized psychiatric support teams wasn't able to do in the past, while addressing the significant delays and safety concerns posed by reliance on external ACT teams. It is for this reason that I urge the committee to pass Senate Bill 243 to help to improve the home health care system, protect nurses, and ensure better health outcomes for patients with complex needs. And before I log off, I wanted to just publicly thank Senator Anwar for being willing to come into the community, listen to our concerns, and giving us a voice. Thank you.
Thank you. Don't log off. We have a number of questions for you. Thank you, Ms. Harriet. I've had the opportunity to learn about the clients that your home health agency is taking care of, and your home health agency is also taking care of individuals no one else would take. And then many of the gunshot victims in this in Hartford or across the state, for that matter. Did you have a chance to listen to the commissioner and commissioner's concerns?
Yes, I did.
How would you respond to that? Because the commissioner's thought is that the ACT teams have their clients, there's a waiting list, they don't have any capacity to take on more people. So how do we bridge that gap?
So we can bridge that gap because home health, we're covering a lot of the shelters. We're in the community. We're already in homes. And usually we're finding people that's not connected to the system. We're finding people who have recently left incarceration, not even diagnosed with a mental illness or aware that they may have mental health disorder. We know that in communities where, they're underserved or Black and brown people, we're more likely to be underdiagnosed with a mental health disorder due to fear, the stigma, and also lack of resources. In 2020, Senator Olsten did a report on the Department of Correction. She actually requested this, and it was found that most of the people who needed mental health services didn't receive it. Many of who ended up, incarcerated where they really didn't get mental health services then. And then when they're leaving from incarceration back to the community, they're still not getting their mental health services that they might need. And so if we know that, some criminal acts are committed from people who may be experiencing command hallucinations, persecutory delusions that others in the community are putting ideas in their head, especially when we pair that with substance use, we then might see deviant sexual interest or people being willing to engage in sexual activities that's not welcomed or with people who don't consent to that because they're just not in the state of mind to make better decisions. So while we understand that having a mental illness does not increase the risk to violence, we know when you pair it with substance use, and we know when you pair it with communities riddled by violence, the risk of trauma is increased. And so we put nurses, family members, and the rest of the community in this situation without the support of ACT teams, because when we call, we're begging. And then when folks get called via a phone call, as the commissioner said, you know, they might say what sounds okay, but that doesn't mean that what the nurse or the community is witnessing in person is correlating with what a phone call might say. And many of our patients, they don't even have a phone. They don't have access to a phone line. So if we're going to call a mobile crisis or an ACT team who's going to rely on a phone call, they're never going to reach the people who we're talking about, the transient folks who we're finding under bridges or just living somewhere where they don't belong. Many of our patients don't even live at an address that exists. They take the number and they write something else on the door, so there's nowhere to find them. We're talking about that group of people that need untraditional healthcare services and need it quickly, so they're not at risk and the community isn't at risk. Thank you.
And I'll just ask one more question and I'll have my colleagues have an opportunity as well. We are not asking for a policy change. We are asking for a pilot because the current situation that you very nicely and professionally explained is not working. And then there is area of opportunity. So we need to create a pilot to see if it works. And then perhaps then we can go back and see if there's a policy opportunity to change. But there's no change in the policy. There's only an ask to say, hey, can we do something differently and then help some of these situations and protect our healthcare workers? Is that a fair way to put this?
Senator Anwar, thank you for that. That's a fair way. I'll go back to the pandemic. Harriet Home Health Services, I remember when I reached out to Commissioner Deidre Giffords at the time, and I said people at home need to be able to get tested and they need to be able to get vaccines. And that policy didn't exist, right? That idea of a pilot going in home and delivering services, which then, you know, the commissioner at the time said, you know what? Let's see what would happen. And I appreciate that because from that, we were able to vaccinate people who were homebound, people with cognitive challenges, people, their caregivers, and the people who couldn't line up, the people who couldn't use VOMS easily. And then it turned into where we then had folks who were at risk for Mpox. And then we can go and do Mpox vaccines under bridges at fast track. So we're asking to be creative. We're asking the leaders of the state to look at ways to decompress the hospitals, current ACT teams that's, you know, there's some flaws, and we're asking to just give a pilot a chance. Will it hurt to do the pilot, or would it hurt to go without it and see what happens next year, the following year, or next week? What's going to happen to the folks at home that might be waiting for months for this level of support? That's what we're asking. Thank you for that question.
Thank you. Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming and testifying. And, you know, listening to you is really good. And I'm curious because even in my town, we had 2 incidences, and it was mental health, and actually had a call with the commissioner of DEMAS and DESP because our police were involved. DEMAS was involved, and really, unfortunately, all we heard was we need to communicate better. And, you know, our police department communicates with the DEMAS workers 5, 6, 7, 8 times a week, because in my town, we have there's 6 people that are red flagged that could be a potential, it could turn into a disaster, of tragedy. And so my question to you is, and we have the concern of you, the healthcare worker. We know that going into some of these places is, it's not.
Recording in progress.
Does that make
I think you have two phones open. Sorry. Sasa, if you want to turn the other one off.
Yes, I fixed it. Sorry about that.
That's okay. And so I guess I just would like to know a little more about this act, because I think we need to try anything we can to help these people and to keep our healthcare workers safe that are going into these situations. So can you just tell me a little bit more about this ACT team?
Sure. So our proposal would be an ACT team that would involve combining a multidisciplinary team, which would include psychiatric doctors, psychiatrists, nurse practitioners, board certified mental health nurses, and law enforcement, and to ensure that that team can work together. And we would then have a way of looking at high-risk individuals, working with the Department of Corrections, hospitals, local mental health authorities to say, okay, we know that the individuals who might surface where the community is calling, the Department of Corrections know that someone's going back to their community that may be high risk, right? But their sentence ended and they're going home. Family members, clergy, whoever can say, I'm concerned about this individual. And we would work together as a team to ensure that the patient or the community member receives in home or wherever they live. The team would evaluate, provide services, help with medication management. So this would be a special team that would see individuals based on their psychiatric symptoms and support them. So support them if there's issues such as case management, being homeless, when they're engaging in high-risk behavior. So we're not waiting for someone to commit a violent act or appear to be in crisis. We're working with those who are likely to be in crisis or on their way to that and to prevent it. So we're doing preventable, secondary and tertiary. We're working with all groups of individuals to make sure that they don't end up in crisis. We're there before. Current ACT teams or mobile crisis teams, you're waiting until someone's escalating. And then we're going in. We're saying we want to case manage and support the individuals that's the highest risk in this state and be there well before to support them. Because I believe as medical professionals, we can predict based on certain diagnosis, substance use disorders, and past history of trauma, what might happen to someone when we bring them back to their community.
Right. Yeah, I think it sounds great. And I really hope that it would work. Like I said, even in my town, we have 6 people that the police know of that it could be tragic. And so I'm very interested to learn more about this and to, once it gets going, I hope it is reported back to us, all of the statistics and the great things that hopefully this team will do. And my last comment is, you mentioned about prisons and hospitals. And unfortunately, that is where people with mental disabilities, that's where they end up. They'll have to go to the hospital or into prisons, and they're not trained to do that. They should be in a different kind of a place, but that's for another day. But thank you so much. I will be very interested to see how this pilot program works.
Thank you.
And I have Representative Claridis Dietrich who has a question.
Thank you, Mr. Chair. Thank you for your testimony today. I do think, as you've heard from most of us, this is very important work that we need to help with our disabled community. A couple of my questions: how long would one anticipate to follow each person through this process?
Great question. So in home care, for example, we have some individuals that come on services and it may be short term. Most of our clients who have chronic serious mental illness. We're by their side for years. We're by their side for years, and services, we may front load it when someone's going through a crisis or on their way, or there's something going on, like you couldn't get your medications prescribed by your doctors, your insurance ran out, a family member died, whatever may happen. So in home health, we're used to being able to set up a treatment plan and a care plan alongside physicians to say, we believe this person should receive services twice a day, for example, or twice a week, and for X amount of weeks. So we would use that same model because we know that there is no medication to cure serious mental illness. There's supportive medications, and people may move throughout the recovery process based on what's going on in their life or the aging process where the brain might deteriorate or substance use, right? So we're there to support the community through that. And we're not going in just because there's a call and then saying, okay, we spoke to you. We're going to connect you to someone external who might see you 3-5 months down the road. We're there, and we're there to support that member for, as long as they would need the services. So this is ongoing because we know it's a lifelong process.
Thank you. And then to adding on to that, at what point does the healthcare team, do they decide as a unit that this person no longer needs the services, or does each service have to say, okay, they're ready to be out in the community without any more of our help and services?
So it would be a team approach, but because we have different steps, we're proposing different steps. So from the psychiatrist, the psychologist, APRNs, and then also mental health RNs. So currently we have visiting nurses on their own, right? Going in a home and just managing meds, calling a doctor remotely when there's an issue. We can have a step down process within the ACT team to where, okay, you have progressed to now the nurse is the primary contact, but the ACT team is still there. We're having weekly meetings. We're case conferencing on high risk clients, and we're discussing every step of the way. So the entire team would be treating and making decisions. And if that visiting nurse or registered nurse involved said, I'm a little concerned, then we have to bump back up to a step where we may have reduced before.
Okay, thank you very much for that clarification. Thank you, Mr. Chair.
Thank you. Representative Terciak.
Sorry about that. Thank you very much. Thank you very much for coming to testify in front of us today. One thing that I'm not sure is being given enough weight with your testimony is, thanks for actually saying how important ACT teams are and how when they're working right, they work great. I was on an ACT team when I first, and had to leave when I first got elected, at which time I switched to home care psychiatric nursing. We're not working with a population the size we used to 20 and 30 years ago. The idea of having the ACT team model spread and be tailored to specific agencies from this old ACT team guy makes perfect sense to me. I'd hate to try and deal with something that needs to be done so quickly. I mean, so thoroughly in as quick amount of time as we have in the session. So the idea of study groups, of suggestions, task force, I don't care what you want to call what you correctly say we need to be looking at. Taking a bit more time is a very good idea, I think. I look forward to working with you and your group. And thanks a lot for coming in front of us. This is a very good thing. Thank you. Thank you very much, Mr. Chairman. I appreciate the time.
Thank you so much. So Ms. Harriet, not seeing any more comments, I just wanted to make one comment. When you described about mental health in the community and how careful you were to make sure that we do not stigmatize it, and mentioned the fact that anyone with mental health or substance use is not a risk to anybody except in very specific few circumstances. That was very critical part of the conversation. And I appreciated your professional and very articulate way of making that comment. I just do see Representative Reddington Hughes has a comment
Thank you,
or a
Mr. Chair.
question.
And thank you for being here or being online. My question pertains to what the estimated cost of this program would be. It certainly is something that sounds like it's very needed, but as a legislature, we really have to also look at what this would mean to the state as well.
Sure. So we estimate that for the care, which sorry, I don't know why. For the care for an entire team of around 60 to 100 individuals to be managed multiple times for the week, it would come out, it would maybe be around $4 million for the ACT team, but where we would not see the cost go up would be, for example, someone that's relying on an ACT team and getting the services for medication, the psychologist, psychiatrist, and everyone, that $4 million would be saving the state a lot. Here's why: because what it would cost for a visiting nurse to see someone BID, 60 people per year, what it would cost to provide transportation to bring those individuals to a doctor's appointment where they might show up late, miss the appointment. The psychiatrist waited all day for them to come. They didn't show up because they're unable to coordinate the transportation that they need. What it would cost for them to be hospitalized, the police department to continuously show up, family members not to go to work when family members are in crisis, what it would cost compared to $4 million a year for an ACT team to take care of 60 to 100 people. It's saving the state a lot.
So if I'm correct in the answer, then it would be $4 million to serve 60 to 100 people.
Yes.
Oh, thank you.
Thank you.
Thank you so much. Seeing no other questions or comments, we will move to the next person. Thank you, Ms. Harriet. Next person on our list is Kelly Moquette. Welcome.
Can everyone hear me?
Now we can. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Vice Chair Senators Kushner, Marks, ranking members, and members of the Public Health Committee. My name is Callie Moquette, and I represent Health Equity Solutions, where I am the Senior Policy Manager. Thank you for accepting this testimony in support of HB 5293. On behalf of Health Equity Solutions, we are a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices. Our vision is for every Connecticut resident to attain optimal health regardless of race, ethnicity, or socioeconomic status. Each year, HES engages in community conversations with Connecticut residents to inform our policy agenda. Since 2020, we have engaged in over 570 participants across 47 towns and cities. The ability to afford and access quality health care has consistently been among the top 3 health equity priorities for Connecticut residents and was noted by participants to be a significant barrier to their families' ability to seek health care. Furthermore, during our community conversations this year, we heard from many participants that they want a more integrated healthcare system that encompasses better access to dental care and improved access for people with disabilities. Commonly reported challenges individuals with disabilities face include accessibility, physically ergonomic correct furniture, and the absence of assistive technology with dental care. Additionally, caregivers of individuals with disabilities often lack proper training, education, and support needed to provide safe, adequate care or advocate for necessary services on their client's behalf. HB 5293 would support many of these families by providing critical resources such as training, self-advocates, and information to attain the best possible care. In November of 2023, the Office of the Child Advocate conducted a systemic review into the care received by individuals housed in state licensed facilities. OCA's investigative report identified deficiencies in the safety net and services for disabled individuals in DDS licensed community living arrangements. DDS must implement practices that educate the patient and caregiver on the necessary steps to treat their condition. Providing additional training for the professionals will aid in them giving the best possible care to their community. The recommendations encompassed within HB 5293, such as the establishment of an oral health and dental services unit within DDS, would ensure that residents with intellectual and developmental disabilities, as well as their caregivers, are afforded the proper resources. Connecticut takes pride in finding ways to advance the health and well-being of its residents. The passage of HB 5293 would allow us to keep moving in the right direction. HB 5293 would ensure that individuals with intellectual and developmental disabilities receive the quality of care and services they so desperately need and deserve. I appreciate the opportunity to present this testimony in support of HB 5293 and act concerning the developmental services recommendations regarding various revisions to developmental services statutes. I respectfully urge the committee to consider passing HB 5293. Thank you.
Thank you, Ms. Mokat. Just in time. You did a very good job.
Thank
And
you.
seeing no questions or comments, we want to thank you for your testimony, and we move on to the next person on our list. It is Dr. David Barton. Welcome, Dr. Barton.
Right. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Dr. David Barton. I'm here to speak strongly in support of Bill 5290, specifically regarding Section 8, which is in regards to the permitting of anesthesia in dental practices. I just want to take this opportunity to relay to you how our current system is working and really, not working, and how it's dysfunctional, how we need to put in some fixes. So I am a dental anesthesiologist. It's one of the 12 recognized dental specialties. Our focus is to work with other dental providers to safely bring sedation and anesthesia to particularly pediatric, special needs, and anxious patients so that they can have their treatment needs met. I'm contacted by dental offices daily looking for ways that they can safely treat their patients. To do that, currently in the state of Connecticut, we have to undergo a permitting process in every single facility that we work in. This has two major issues as it is constructed right now. We have to put live patients to sleep every time. I myself have been inspected in about 20 offices, meaning I've put 40 patients to sleep for an exam that is the exact same every single time. The dental offices are often the ones required to provide these patients, and if they don't find appropriate patients, they are asking their friends, their families, their staff members to volunteer to be put to sleep so that they have the opportunity to receive their inspection, which puts us in ethical conflicts sometimes. But the offices need these inspections so that they can treat the patients who actually need the anesthesia. Those cases are often too long, so they don't fit the parameters that were given to find, given to, demonstrate the facility's preparedness for the inspection process. These permits also typically take between 6 to 9 months. That's what we've seen in our practice. So those are the two biggest issues that I have encountered, dealing with this system. That is why I'm strongly in support of the amendments that have been brought. And really, as we continue to work on this, I think we can find, better ways to solve this issue and provide safe care across the state for all the dental patients that require sedation and anesthesia for their treatment needs. Thank you for your time.
So thank you so much, Dr. Barton, for your testimony. So you're saying that if we pass this bill, our constituents will have less pain.
That's what we're always trying to accomplish.
Okay, thank you. That's very convincing. Yes, Representative Claritas Dietra and Representative Zupkus, and
Thank
then
you.
Representative Palma.
Thank you, Mr. Chair. Thank you for your testimony. As an anxious dental patient who's had sleep dentistry, I think this is very important. So hopefully we'll be able to move this legislation forward. Thank you for what you do. Thank you, Mr. Chair.
Thank you, Representative Zupkus.
Thank you. And from somebody who is scared of needles, I would never volunteer for that. But so if you have 2 offices and then you go to 5 different hospitals, you would have to have 2 practice on 10 practices, basically, 2 at every place. Is that what you're saying?
Yeah, so each new dental office
Yeah.
that requests my services, I tell them, excited to be working with you. We're going to go through this inspection process first, 6 to 9 months roughly, and we're going to need to have 2 patients that you're going to have to find that I can put to sleep so I can be observed providing anesthesia in this office.
Right. So lay on the table, let me knock you out first. And then
Pretty much.
we'll
And it
figure
doesn't
out
matter how many
we're gonna do.
times I've done it in other offices, I will have to do it again.
Right.
And,
Okay.
if that office is struggling to find patients, well, your day has come and gone. You got to wait, back into the queue another 6 to 9 months.
Right. Well, I too hope this moves forward.
Thank you so much.
Yes, Representative Palm, sorry.
Thank you, Mr. Chair. Hi, Doctor. Thanks for being here. Is nitrous oxide one of the methods that you still use?
Nitrous oxide is a commonly used drug. Now, if that's the only drug given for a sedation, that wouldn't qualify for the need for this type of robust, permit. There's conscious sedation permits, deep sedation permits, things like that, that are dealt with. But nitrous oxide specifically, that wouldn't require.
Okay,
Yes.
the only reason I'm asking is I'm actually thrilled to be able to vote on this bill because Horace Wells is a personal hero of mine, and thank you. And as we know, he suffered terribly because there was not this kind of regulation, this kind of opportunity for doctors to learn without practicing on themselves. And as you all know, he died of chloroform poisoning, probably intentional. And it was so tragic long before there were regulations to help good doctors like him trying to do the right thing. And I feel his spirit guiding me when I take this vote with great excitement. So thank you for your work.
Thank you. I greatly appreciate that.
Thank you. And when you come with Dr. McDonald, with you, it's like, what can we do to help you and do the right thing? So we appreciate you being here. Thank you so much for your testimony, and thank you for being here.
Thank you so much.
And next person on our list is Elizabeth Guerra.
Thank you, Senator. Thank you, members of the committee. My name is Elizabeth Guerra. I'm the executive director of the Connecticut Waterworks Association, which is a trade association of municipal, private, and regional water utilities that provide service throughout Connecticut. Just here quickly to talk about some of the provisions, 2 of the provisions in House Bill 5290, the Department of Public Health's recommendations regarding various revisions to the public health statutes. Section 3 of the bill simply clarifies that water companies must be notified of any proposed change of use in an aquifer protection area or watershed land by replacing the word project with land. And I think that this helps avoid some confusion as to when such notifications are necessary. I know there was a question earlier as to why landowners are not similarly notified. I do want to point out that this statute is actually in addition to the statutes requiring abutting landowners to be notified under the zoning statutes. And this is necessary because there are some watershed lands that are not owned by the water company. And so it's important for the water company to be notified of those any changes on those lands that may affect the integrity and quality of the public water supplies. Once they are notified, then water companies have the opportunity to weigh in on how the proposed project may end up impacting water quality and availability. So again, very important statute, important to our source water protection efforts. And again, we support the change that the department is looking for. In addition, on Section 9 of the bill, this simply codifies existing practice relative to the use of certified operators in training. And currently, there are these water system operators in training that are used in order to operate water treatment plants and distribution systems. And this is, again, just simply codifying that they can be used in the statute. And this is important because water companies are required to have a certified water operator at their distribution and treatment plants at all times. There's currently a shortage of these water system operators. So ensuring that water operators in training can continue to serve this role is important. Thank you.
Thank you for your testimony. We appreciate you being here. Seeing no questions or comments, we'll move to the next person on our list, which is Jonathan Ryan. Welcome, Mr. Ryan.
Hi, thank you very much for having me here today. My name's Jonathan Ryan, owner of Aquamation of Connecticut, one of the two firms here in Connecticut going to be offering the new form of disposition, alkaline hydrolysis, that's mentioned in Bill 5290. Like to express my support for the bill, specifically that the process take place under the care of a funeral director. I think that's very important given the personal nature of the process, that it be conducted by a licensed funeral director inside of a funeral facility. So I thank you very much for having me here today. And that would be the only thing I have to say, that I support the bill as it's written. Thank you very much.
Thank you. We appreciate you being here, and this is helpful for us to make the best decisions. Thank you so much. And seeing no questions or comments, we move to the next person on our list, which is James Icobalis. Welcome, James.
Good afternoon, distinguished members of the Public Health Committee. My name is Jim Icobalis. I'm the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association. I'm pleased to be here on a Friday afternoon to testify about a specific provision in one of the Office of Health Strategy bills. We've submitted testimony, and many of you have referenced that, and I thank you for taking the time to read them. But I want to focus in on Senate Bill 242. And this is section 1 of 242. And I think it would be helpful if I give a little history here, because I think it will bring back some memories for many of you. Back in 2021, the Office of Health Strategy proposed changes to the Community Benefit Reporting Program. They were extensive changes. They were looking to significantly increase the amount of reporting hospitals had to do. At that time, the chairs of the Public Health Committee said to us, go work with OHS and see what you can come up with. And we spent a lot of time with, at that point, Executive Director Vicki Veltri, her attorneys, the attorneys from the Department of Social Services, and worked through the reporting that we would provide. And we came to an agreement. But we came to it late, and if you remember, 2021 was sort of just sort of coming out of COVID. It was a challenging session, so we didn't have time to pass that bill. 2022, we all went back and reaffirmed our agreement in understanding in relation to what should be filed. That was passed, and I think it was passed as part of a larger bill, and throughout the conversation, we said, we're going to stick to what this agreement is, and we're going to put it in place. In October of, I should back up, that bill required significant reporting for Connecticut hospitals on what they file with the federal government. We'll take what we file with the federal government and provide reporting on a template that OHS would provide. In addition, we agreed to provide specific state reporting, and the reporting that wasn't required by the federal government, but we agreed to it. And part of that conversation was, we need data from the all payer claims database to do this. October of 2023 comes around, and we had been working with OHS to create, they said after we passed the bill that we now had to go through the whole APCD release part, which wasn't contemplated in the bill. But we said, okay, they created an application. They then created a data use agreement, not unusual, and hospitals began their annual reporting in October of 2023. OHS presents this bill, which unties what is a key part of that agreement. The key part of that agreement was, we would provide state reporting, but we need the data to do it. And if we don't have the data, we don't have to do the state reporting piece because it's enhanced reporting. It may be information that we agreed to provide with the data on populations that we may not have information about. So those were tied together. Section 1 unties them. So our concern is that we have, in good faith, worked to establish this agreement. It took a couple of years to get here, and we are untangling it. So we either urge the committee to not pass Section 1 or go back into the community benefit reporting and pull out the enhanced reporting pieces, and we'll continue to file the federal pieces. We also
Jim, I'm sorry, but your time is up.
Then I am all set. I just wanted to mention one
Actually,
thing.
I want you to complete what you're saying because there are other bills. We're going to probably ask you those questions anyway, so might as well just answer.
Section 2 of the bill requires non-claims data reporting under the all-payer claims database. The Office of Healthcare Strategy, and I think under the leadership of Olga Arma on the all-payer claim database, has done a lot of good work on trying to fill in the data for self-funded plans, the ERISA plans, right? They have commercial, they have Medicaid, they have Medicare, and they've done a lot of work in making progress there, but they're not there yet. We would encourage them to continue down that path to get as much of the self-insured data before we expand it going forward. So either push that section out for some time frame with the focus on self-insured data, or think about pulling it from the bill. As I said, we submitted testimony on other bills related to opioid reporting, which you've discussed, as well as 340B reporting, which I'm happy to answer any questions on 340B. I can't wade too deep into the pool, but I hopefully can answer your questions or get them to you.
Sure. Thank you so much for your testimony, and thank you for being here all afternoon and now moving towards evening. Can I clarify, you said that you would be okay with the bill if we just removed Section 1 from 242?
Yes.
Okay, but the rest of the part you're okay with?
Well, the bill has two sections. The first section, we would be okay if you remove it. The second one, we do think that maybe extend the date out to begin that non-claims reporting would be appropriate, because we think the data is probably appropriate, but let's accomplish what we need to accomplish first before we start to expand.
And if you were to argue that you're already providing some of this data to the federal government with respect to 340B, why don't you send a copy to the state Office of Health Strategies?
Hospitals that, and you're gonna get me into a pool that's gonna over my head really quickly on 340B. The 340B is the federal drug program, which is audited by the federal government. The items that are provided in this reporting is additional reporting. So it is not anything, to my knowledge, that we currently file with HRSA, but HRSA does come in and audit. But let me take a step back here. Last year, there was a provision, as Dr. Gifford said, related to 340B. It was part of the really big bill 6669. If you remember, it had a variety of provisions. We worked through a lot of them, and in fact, we came to an agreement with OHS and the Office of the Governor related to some reporting on 340B. Given issues non-related to hospitals on 340B, it was decided not to put that in the final bill, which is what I think Dr. Gifford said. It got really close, but didn't happen. We don't understand why that language wasn't included, and we took a step back to different reporting. It's different than it was when it started, but it's not what we had come to an agreement with them going forward.
So let me clarify, the information that you provide to HRSA, does the state have access to that?
They do not, is my understanding.
So would the burden be not that significant if the federally mandated information can be shared with the state rather than additional information?
I don't know the requirements of the federal law, whether that is allowed or not, but I will find out.
Because again, it's just thinking aloud, what we are worried about is having too much more additional workload on the healthcare system and so on. So perhaps one of the option is to have the information that you're already collecting and giving it to the federal government and give it to the state. As you heard the commissioner, the perspective is that the healthcare costs are going up. I mean, it's no secret that the healthcare costs are going up for a variety of reasons. But it's important to know the spread that the hospitals are using, and if there's an opportunity within those spreads for the commonest 50 medicines, because our interest collectively is to make sure that the consumers are safe, and the customers or your consumers are going to not be harmed because of the cost of healthcare, whether it's coming from the insurance or through the health hospitals or the physicians and so on. So if there was a way to find out if there are 40, 50 commonest used drugs, if there was a way to try and have a control. So the federal government just put in some amazing thing with the Medicare to be able to negotiate on the 10 drugs and then hopefully increase them every year. Perhaps the state is going to be in the position to do something to that effect on the cost of medication, which is really something that an average citizen in the state of Connecticut is going to benefit from. I think that's the lens that we are looking at long term to see if there's opportunity. So
my understanding is the Office of Health Strategy published a report on the top 10 or 25 prescription drugs. Right. It's not clearly related to 340B, but they have done that. I think, and we'd be happy to circulate and provide you with the language that we agreed to last year. But I think Senator Gordon's question about what is the information going to be used for, and what are the next steps in the thoughts of the process related to this is critical. But I understand your question about what is it that is given to the federal government. Is there something that's translatable? I'm not sure there is, but also get the language that we agreed to last year, which does have increased reporting. But your point, and we can save that for next Wednesday, which is to look at the reporting that is being required. And this bill and the reporting here should not be taken in isolation to Senate Bill 9, which has a tremendous amount of reporting. And we need to be really cognizant of what we're doing in terms of reporting. But I understand your questions, and I'll get back to you on those.
Sure. And again, we have some empathy for the hospitals as well, because hospitals have been struggling and the smaller hospitals are not able to survive. We see that, and then most of our constituents across, because they're spread all over, half the legislature has heard about directly what's happening to the hospitals. So we respect that fact, and we also are trying to see what are the areas of opportunity so that the consumer at the end is not being impacted so much that they're making difficult choices of eating, breathing, or having their medications or staying warm.
Yeah.
Those are the challenges that many of our constituents are facing. So we're trying to navigate how do we help out, and then is there opportunity? But I do feel that the medication part that we have, the list is from Medicaid. What are the commonest lists that we have? So that I've seen that list. But we do not have the list from the hospital medications and the most commonly used ones in that situation. And if there's an opportunity to reduce that cost, and then see what are the comparable areas in different parts. That's my understanding of the broader long-term strategy to have some checks on the cost of healthcare. Anything that we have? Yes, there's a question, Representative Parker, and then we'll have more questions later. Rep. Parker, go ahead.
Thank you, Mr. Chair. Thank you, Jim. It's nice to see you. Happy Friday. Thanks for being with us. Just to your testimony about about 242, it looks like you're referring to line 16 to 20 in that deletion, and I'm wondering, so that requires that the all player all payer claims database is provided to the hospitals. If this was removed, would that in practice not happen? I guess I'm curious, are there other reasons why the APCD is provided and therefore it's going to happen anyways, or help me understand that?
In order to provide the data, right, we can do it a couple of ways. We can do it through the all payer claims database release program, which is where researchers go to provide and to get information from the database about information that they do, or projects they're doing research on. Or the state can make a sort of a policy decision, right? We don't want this data given out without a valid public policy reason. So as part of the bill, we came to an agreement and the legislature agreed that there is a valid public policy reason to give this data. The same data, whether you went through the all payer claims database and completed an application and a data use agreement, we would still have to do a data use agreement, but it would be much easier. It's sort of a different hurdle, which we can do, right? I mean, it's been a lot of work to get there, but we can do that. But the piece is, if you don't get the data to then do the additional reporting we agreed to, that's what was contemplated throughout the process. And that's our real concern.
Right. And so I appreciate my understanding then, or my question is, the reasons why you wouldn't get the data, is that because OHS would make some decision, or because the hospitals didn't do all the steps required to be able to get the data? Do you see what I'm saying? I understand
right.
what you're saying the problem is, but what would cause it to actually not get transferred?
Well, the data release committee could decide for any number of reasons not to give the data out. Or I guess the getting of the data we've sort of worked through, right? It's because they've changed the process and we said, okay, we'll deal with that. We'll deal with the application. We'll deal with the data use agreement. But if the data release committee over here says no, then we don't have any way to then get the data. And then our state reporting, which is required, is going to be difficult to do. And OHS has the ability for penalties if we don't come.
Sure. Have they said no to the hospitals before? Might be a stupid question.
We are still early in that process. It is it's sort of the untangling of this, because in order to do some of this, we recognize that we don't have all the data because not everybody goes to the hospital, right? There are individuals who have claims that would be helpful and information that would be helpful. And this is the same data, whether OHS made it available to the hospitals because we made this public policy decision, or it goes through the data release committee. It's the same privacy protections. It's the same HIPAA coverage. It's all of that is exactly the same. It's the untying of the additional state reporting on the community benefits.
Thank you so much. Thank you, Mr. Chair.
Representative Wieslander.
Thank you, Mr. Chair. I actually just very quickly was hoping if you could please submit your written testimony for 242. Or yes.
It is late coming, but it has been sent in.
Perfect. Just so we can.
No, it is there. It was a week of 20 testimonies, and this was Friday afternoon. So.
Yep, I get it. No worries. All right,
it's coming. It's coming.
Okay. Thank you so much.
All right, seeing no other questions or comments, I'm sure we'll have a lot of conversations and we'll spend many more Fridays together.
Well, save me a seat for Wednesday because I'll be back.
Okay. All right, the next person on our list is Gary Schulman. Is Professor Schulman here?
Yes.
Welcome.
Thank you. Senator Anwar, Representative McCarthy-Vahey, remaining legislators, and members of the Public Health Committee, thank you for the opportunity to speak. My name is Dr. Gary Schulman. I practice dentistry in the town of Glastonbury, and I'm a member of the faculty at the University of Connecticut School of Dental Medicine. My testimony today is in support of the revisions to House Bill 5293 pertaining to dental services for people with developmental disabilities. Specifically, this is Section 2B3 And I do support the provision to allow members of the faculty at UConn to practice dentistry and therefore provide dental care under the aegis of the Oral Health and Dental Services Unit of the Department of Developmental Services. I've been in practice since 2001, joined the faculty at the School of Dental Medicine in 2005. I'm past president of the Connecticut Society of Pediatric Dentistry, president-elect of the Hartford Dental Society, and I'm on the staff at Connecticut Children's Medical Center. I speak today only on my personal behalf and not in any official capacity. I feel that there is a significant lack of access to oral health care for patients with special needs. I also feel that the problem of the lack of access to oral health care is far worse for adults with special needs. The problem of the lack of access to oral health care in Connecticut for patients with special needs may not be fully understood. I will tell you that I am unable to find opportunities for the transfer of my patients as they enter adulthood, no longer require pediatric care. This means that despite my connections, I've always struggled to get care for my patients once they age out of my private office or clinic. I also know that the typical waiting list for adult special needs patients to undergo what is called oral rehabilitation under general anesthesia may be approximately 1 year. Along with 2 colleagues at UConn, we're trying to begin to best understand these issues. The revisions to this bill may provide opportunities for the Department of Developmental Services to deliver healthcare with the personnel from UConn in more settings than exist right now. That means that people with special needs may be given the opportunity to receive oral health care that was not previously available. In my opinion, any changes that can be made locally or statewide that open and increase access to care for patients with developmental disabilities are vital to helping them live healthy and pain-free lives. We owe that to them. Thank you.
Thank you for your testimony. This is very helpful. Seeing no question or comments, thank you so much. We'll move to the next person on our list, which is Claire Sawyer, number 18. Actually, I think Claire is not here. We'll move to number 19, Sabrina Trochi. So let me see, 18 and 20 are not here. All right, 21. Next is 21, Tanaya Taylor.
Hi. Hi. Thank you everyone for your work and for listening to us. I am here to testify for an act concerning the Department of Developmental Services, recommendations regarding various revisions to developmental services, HB 5293. I am testifying on behalf of the proposal to expand access to oral health for individuals with intellectual and developmental disabilities. I think this is an important service that needs to be expanded. Please support that work. Thank you so much.
Thank you. That was the shortest and to the point testimony. You have the award today. Thank you, Tanaya.
Thank you.
And I think the next person, we don't see any question or comments. We appreciate you being here. Number 22, John Hilligan or Hilligan. 22. Going once. Going twice. All right, moving on to 23, Christopher Ryan.
Oh, hi. My name is Christopher Ryan Sr. I own Gleason Ryan Funeral Home in Torrington and Ryan Funeral Home in Lakeville. And I'm speaking in support of Bill 5290 in regards to alkaline hydrolysis. I did want to mention one aspect that I thought was important, mentioning that if this is granted and passed and so forth, that the the statute has some type of wording in it that mentions that only a licensed funeral director or embalmer in the state of Connecticut handle the process and the deceased during this process. I think it's very important that that be the case. And also, like I said, maybe some training and so forth in regards to procedures that will take place during alkaline hydrolysis if it is allowed in funeral homes. So basically, that's all. I'm in support of the bill, but like I said, I just wanted to mention that I think it's important that it be that a licensed funeral professional, bomber or funeral director, handle licensed handle the deceased that are taken into care and handle alkaline hydrolysis.
Thank you so much for your testimony. We appreciate your testimony and it helps us. Here's a question from Representative Reddington Hughes.
Oh, welcome, and thank you for being here. I just had a quick question on the cremation. When this is all finished, does the individual take the whole thing?
Yes, well, there is effervescence or fluid that is left after the process, and also there is bones that are then broken down further as part of the process. So just as in with fire cremation, same type of situation. But the alkaline hydrolysis is a much cleaner and much more earth-friendly type of cremation. So it is important that, like I said, when somebody's delivered to the crematory, we use crematory in Waterbury. There's state guidelines. They have to be in some type of rigid container when they're delivered to the crematory. They're also in a pouch. If somebody is unembalmed in Connecticut, it's required that the deceased be placed in a pouch for transportation purposes. So if somebody should pass away at home and then is transferred to the funeral home, we would do that. A licensed funeral director would do that at the funeral home as part of what is part of sanitary care, and it's what we do for the individual. It is very important, and like I said, I feel it's very important that only a licensed funeral director handle the deceased at the funeral home and perform the process. I think there could be great problems if we're allowed to, if weren't licensed, weren't knowledgeable on the process, to be handling the deceased, and I think there could be a great number of problems that could arise. So that's why I feel very strongly. That's why I'm speaking.
Thank you.
Thank you, Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for your testimony. What's the difference in cost?
It's relatively a little bit more expensive to perform the alkaline hydrolysis, chemicals and so forth that are required. As far as, I don't know exactly. It would depend on the weight of the individual. And actually, my son is much, who works with me at the funeral home. He's much more involved in this process than I am, and can answer questions much more accurately than I can.
Thank you. Thank you, Mr. Chair.
Thank you. Thank you for your testimony. Seeing no other questions or comments, we move on to the next person on our list, which is Mr. Michael Safian. Mr. Safian, welcome.
Thank you very much. Mr. Chairman, Madam Chair, members of the Public Health Committee, I'm Dr. Michael Safian, a board-certified oral and maxillofacial surgeon practicing in Shelton for 20 years, and as Associate Program Director at Yale New Haven Hospital for our residency program. I'm past president of the Connecticut Society of Oral and Maxillofacial Surgeons, and I'm currently the president of the Connecticut State Dental Association. I rise to speak to House Bill 5290, specifically Section 8, lines 282 through 348, and speak in favor of the section, but I would like to offer suggestions to improve it. The CSDA has always had a strong working relationship with the Department of Public Health, cooperating on various projects over the years, and we appreciate the work they put into developing and raising the important changes to our state statutes. This represents many years of meetings, discussions amongst our association's anesthesia experts, the CSOMS, and the DPH. We do, however, feel that while there are excellent sections that will improve the dental anesthesia license inspection process, we believe it needs only small adjustments to become perfect. In regard to Section D, we believe the section has merits to improve not only the dental anesthesia process, but also improve a pathway to a more up-to-date list of medications and equipment that will improve our practices and provide a high level of safety for our patients. We support the section completely, as well as sections A, E, and F we support without changes. Section B and C are where we hold our greatest concerns, but also our greatest excitement. For many years, Connecticut's inspection process for dental providers who administer moderate, deep, or general anesthesia has provided a high safety level, but was balanced with an unduly difficult process that has affected the access to care for many of our patients who suffer from dental anxiety. As it currently stands, and would still with these changes, a dentist cannot simply call a dental anesthesiologist to come to their office and sedate an anxious patient in the next week or so. The dental anesthesiologist would first have to call the DPH and the Connecticut Society of Oral and Maxillofacial Surgeons to arrange an inspection and evaluation of that dentist's office, a process that currently can take up to 6 months, sometimes even longer. Meanwhile, the patient is waiting for treatment, possibly developing increased dental general health problems and at risk for abscesses that could land them in the emergency room or the operating room for life-saving surgery. I've been the operating surgeon for far too many of this type of cases, and it's always a sad story. Sections B and C take a great first step at improving the process by allowing for a waiver process for that anesthesia provider, but only if that new office had been site evaluated and visited in the previous 5 years, possibly even with a different provider. Since Connecticut does not currently have a permit process for the office or site, and only for the provider, any site visit based really on the skills, abilities, and equipment maintained by the provider evaluated. There is almost nothing about the office itself that is being evaluated. We therefore believe these changes don't address the problem, as they attribute too much to the anesthesia site and not enough to the provider itself. We suggest that a waiver program that allows any provider of anesthesia to request a site visit waiver for any satellite office would better address the current system's problems and make a better workflow, create a safe environment, and satisfy our patients' needs. For example, as currently written in this bill, an evaluation would have been done in the office of Dr. Smith 4 years ago for a dental anesthesiologist, Dr. Brown. But now Dr. Green wants to provide the anesthesia in Dr. Smith's office. Dr. Jones can ask for a waiver based on that 4-year-old evaluation, which had nothing to do with Dr. Jones, his skills, or the quality of his emergency supplies. It is as good as not evaluating Dr. Jones at all in that new satellite location, which is what we suggest. If we accept the premise that the site evaluations are done to ensure that our anesthesia providers are safe, and therefore our patients are in safe hands, under the current format of a provider and not a site permit, we should attribute the waiver process to the provider and not the site.
Excuse me, Dr. Safian, your
Yes,
time
ma'am.
is up, but thank you.
Thank you. If I may just quickly, Dr. Hilgen, who was number 22, got booted off. He texted me that he's available if he could be let back.
Yeah, we will. We found him and we're going to take him next.
Great, thank you.
Do you have a written testimony? Because there were a lot of specific recommendations you have had.
I do. It will be submitted on Monday.
Okay, please do that. Send them and we'll look at them again. Thank you
Thank
so
you
much.
so much, Mr. Chair.
There is a question. Wait, Senator Gordon.
Dr. Safian, thank you for testifying on this issue. One question I have for you is, what are other states, such as other New England states, what do they do with regards to handling this issue, with regards to waiver requests, on-site visits, that type of issue? Do you know?
Yeah, they do different things. When we look at the New England states, Massachusetts, Rhode Island, Maine, and New Hampshire all have a separate license for the site, as well as a separate license for the provider. So they're done differently in that regard. The American Association of Oral and Maxillofacial Surgeons has a waiver process for their providers to basically say, I do the same thing in the satellite offices I do in others, and there are about 14 states that use that.
Thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, we wanted to thank you for your testimony and going in so much depth, and that's very insightful and helpful.
My pleasure. Thank you.
Next person on our list is Dr. John Hilligan. You're on. Welcome. Dr. Hilligan, you can unmute yourself and turn the camera on, and you can speak.
Thank you so much. Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Dr. John Hilligan. I'm a board certified oral and maxillofacial surgeon, and I practice in Waterbury for more than 28 years. Currently, I am the chair on the committee on anesthesia for the Connecticut State Dental Association. I'm here to testify on behalf of the members of the CSDA in support of Section 8 of House Bill 5290. Over the past decade, the Connecticut State Dental Association and the Connecticut Society of Oral and Maxillofacial Surgeons have been collaborating with the Department of Public Health to update the dental anesthesia regulations to make them more contemporary, with increased clarity, and to increase patient safety while decreasing the administrative burdens on the dentist and the Department of Public Health. Through many failed attempts to achieve this goal, it has become apparent to all interested parties that the best means to correct these regulations requires amendments to these corresponding statutes. The overriding goal for any amendment to the statute is ultimately patient safety. These proposed amendments to Section 123B of the general statutes presented remain steadfast to this goal. As it exists in our current regulations, all required medications and equipment are explicitly stated, which presents safety issues for the patients in this state. As newer, better, and safer medications and equipment become available, and as other medications become obsolete or unavailable, the current regulations don't allow us to change these lists without a regulatory change. The recommended statutory changes will remove both the medication and the equipment list from the regulations and places them in the department's internet website. This will allow for timely changes to be made as needed and will increase patient safety by providing the newest standards of care. Our current regulations lack clarity concerning the applicant's initial evaluation. The most recent interpretation requires that an applicant to have an initial on-site evaluation to include the observation of anesthesia provided to 2 patients at each location. There's been no evidence to support that these observations have produced safer providers, but comes actually from past intuition. These observations have made many patients receive anesthesia for unfair examinations and has resulted in the failures of examinees due to factors beyond their control, such as patient compliance. The recommended changes proposed will provide clarity on these initial evaluations and allow for the removal of observation of anesthesia on patients. It will continue to maintain the high standards on the applicant and the on-site evaluation through the review of office equipment, personnel, emergency medications, and examination of emergency scenarios. The existing regulations as written have created undue burden on the Department of Public Health and the Connecticut Society of Oral and Maxillofacial Surgeons, as well as the providers, such as Dr. Barton, who testified earlier. These regulations currently require that each provider at each facility must undergo the same on-site evaluation, regardless of having successfully completed an evaluation at a prior site, at a provider site for a waiver process of unnecessary evaluations or for an already permitted provider. By granting a waiver.
Hilligan, I'm sorry, but your time is up. Thank you.
You can summarize your last sentence or so.
Sure. By granting a waiver to a provider that complies with these guidelines, it will allow for portability of the permits and reduce the number of applicants for review. In summation, the CSD's opinion is to deliver safe anesthesia in dental offices, and the evaluation of the provider and the site is paramount. Our current statute regulatory process from a contemporary, thereby maintaining a burdensome system. This proposed statute will allow the DPH, the CSD, and the CSOMS to achieve many of our shared goals. I urge you to support HB 5290, Section 8, and would like to thank you.
Thank you so much.
Any questions?
I just wanted to just say that you're basically say 5290 is good, right?
We approve it. It definitely makes it a safer it makes it safer for the residents of the state and provides a less burden system for everybody. I've been working on this for 10 years. We're finally at a point where we actually come to some place where we can all work together.
Well, when we hopefully pass this, we should have a celebration. So
Thank you so much.
Thank you for your testimony.
Thank you.
And the next person on our list is Diane Lauricella. Welcome.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, ranking members and esteemed members of this committee. My name is Diane Lauricella, and I am a semi-retired environmental health consultant from Norwalk that was a hazardous waste investigator with the DEP before it became DEEP, and worked then when needed with the Department of Health's toxic section. And in that role, I saw a variety of backgrounds of our sanitarians and our local health directors in their local health departments as far as their ability to do the work that is needed for today's emerging issues in toxics, climate change, heat, and the like. I'm also a member of the governor's GC3 task force in the Environmental Justice Working Group. My comments today focus on House Bill 5290, where I'm happy that these periodic updates take place and am in general support, but there is a need for consideration of the following sections. In section 3, I have a real concern that others have mentioned with the confidentiality issue. And I just wanted, with the issue related to making, I'm in support, except I'd like you to consider making the designation of that particular land use application comported with a town clerk recording. Every town has and city has a town clerk. I am in favor of this particular section being improved upon because I really believe I see a lot of land use laymen that don't understand what a aquifer area is and a watershed. Also, section 16, on line 844, I ask that the commissioner must disclose, not may, must disclose when to an owner and or others that are listed, prospective buyers, when there is some kind of contamination. I share the concern that has been mentioned before with the health department in Eastern Connecticut that we want to make sure the public is aware of potential problems related to discharges and just if someone has a home furniture stripping hobby and they inadvertently have contaminated their neighborhood, their neighbors' wells. That has happened. It does happen. Line 852, I wanted to ask that you please consider adding PFAS, the forever chemicals, as to be a mandated contaminant of concern that is approaching important crisis levels. Line 899, as far as the local directors of health, I ask that you add in line 908 the assistance of a trained hydrogeologist that would be on call with the local health directors. I have yet to meet a local health director, at least in Western Connecticut, that has the training and understanding to understand when there are reasonable grounds to suspect there are a need for contamination in a well. Next year, I think we should.
Norcella, but your time is up.
May I, if I could please just summarize, or if someone could ask me a question on section 18?
Yes. Do you have any comments on section 18?
Yes, thank you. As far as what to call our sanitarians, who are, of course, trained in various things and so important in the fabric of a local city or town, I think to solve the issue of what to name them, and I do understand the concerns that have been mentioned, let's just call them environmental health sanitarians and call it a day. I think that we need to make sure that our current sanitarians have enough enough training, which I do not see, to meet the sense of urgency related to climate change and also our legacy of industrial toxics and toxic waste sites, so that when they are given reports, they either have the ability and the power to insist that a consultant be hired when needed to let them know what is and what is not a potential hazard. I do not see a consistency for
Ms.
them to.
Marcella,
Yes.
Thank you so much. Thank you. We appreciate your testimony. Do you have a written testimony as well?
I was trying to put, I do have one and I can send it. I ran out of time today and yesterday rather.
But you've really dug very deep into it, and we appreciate your thoughtfulness. We will definitely have this in consideration. Your testimony was very thorough, but if you have it in a written format, it'll really help us out.
Okay, thank you very much. I appreciate you staying, all of you staying this late.
Of course. This is like morning for us.
Get some coffee.
Public health. All right. Next is, I think we have Dr. McDonald. Dr. McDonald, can you turn the mic on, Bill? Thank you.
Good afternoon. It's good to be with all of you and the friends of Horace Wells, who is up in the Hall of Fame upstairs in the LOB. So we have to mention him. For those of you who don't know, he's the fellow who discovered anesthesia here in Hartford in 1844. Thank you for holding this hearing today on Bill 5290. And I'm here to support all the recommendations of the Department of Health regarding that bill. But I would like to address the issue which has been discussed by several other people about the use of live patients for the inspection process to get the sedation and general anesthesia permit. I'm a retired dentist anesthesiologist. I've been practicing in Connecticut since 1978, and I retired with the start of COVID because my 92-year-old mother was living with me. I was a staff anesthesiologist at UConn, at John Dempsey Hospital from 78 to 82, and then I went into private practice. And I provided sedation and anesthesia for various dentists, especially for those patients with special needs and children. Since 1984, I provided sedation and anesthesia up at the dental school patients on a pro bono basis until my retirement. The committee should be aware that the majority of special needs patients are insured under the Medicaid system known as Husky. I've held my anesthesia permit since 1985, and in March 21st, 1985, I submitted testimony to the Health Committee with regard to the dental anesthesia regulations, so I've been closely involved with that. I'd like to mention a case that was made aware to me. There was a neglected 16-year-old young lady who needed 6 root canals. Now, you can imagine a 16-year-old having to have 6 root canals. She went to her regular dentist, the clinic where she was treated, and she couldn't even get through having 1 root canal done. So they recommended anesthesia. Unfortunately, there's no endodontists in the state of Connecticut that have an anesthesia permit. So they were able to find another dentist who could bring a dentist anesthesiologist in and treat that young lady. So this is a serious issue. But because there was no endodontist, I think we need that to be available. But anyways, that's a tremendous difficulty. Clearly, the requirement to have 2 live patients for anesthesia done in each office could take up to a year or longer to get the permit done. I must mention that the Connecticut Society of Oral and Maxillofacial Surgeons has really speeded that process up from greater than a year to less than that in most cases. Dentists providing deep sedation and general anesthesia are oral and maxillofacial surgeons and dentist anesthesiologists. In the past 50 years, I've seen a tremendous change in the examination and board requirements for dentists. 50 years ago, and even as long as 10 years ago, we had to be board examined on live patients. We had to do fillings and everything else. You can imagine having to put people under anesthesia is also a potential risk. Anesthesia is very safe, but there is always a risk involved with anesthesia. Oral surgeons, there's now the advent of the mobile oral surgeon and the mobile dentist anesthesiologist. The advantage of that is that the dentist providing the dental care has his or her own dental equipment and his or her own dental staff. He or she can do it much more rapidly than they could in the hospital setting.
Excuse me, Dr. McDonald, but your time is up. Thank you.
Thank you. If you want to summarize.
Okay.
Please.
I think the basic bottom line is one of the 3 dentist anesthesiologists have been inspected in 70 offices. They've had to put 140 patients to sleep. It's repetitive, as you heard earlier. The important thing is for us to upgrade and make more progressive the current examination process so we can make anesthesia available for those patients that need it, especially those who are in pain. Thank you.
Thank you so much. We appreciate you being here. Thank you for your testimony. And Representative D'Amico has a question or
Mr.
comment.
Chair, thank you very much. I just wanted to compliment you, Dr. McDonald, on your most appropriate necktie.
Thank you very much.
How's that?
I
Hey,
could have
wait.
a Horace Wells necktie, but
Don't go away yet. Representative
I'm sorry.
Nicole Claridis Jeter has a question.
Thank you, Mr. Chair. Thank you, Dr. McDonald, for being here today. And I can't sing your praises enough for the sleep dentistry that you did on me many, many years ago. So I see the benefit of it. And I hope like I said before, I hope we can get this over the finish line for you.
Thank you very much. I'm very embarrassed though, but thank you.
I just want to add, she's been so happy with that we were hoping you're going to bring it for us.
Oh, okay.
But-
We'll bring some nitrous oxide.
Okay. Okay. Thank you. All right. With that, let's see, we are laughing. It's already working. Mary Lou Freitas, number 29, Mom.
Hi, thank you so much for letting me come on today. My name is Mary Lou Freitas, and this is my son, Juan. Say hi.
Hi, Juan.
This is Juan. Oh, sorry, I don't know if my camera is kind of weird. Okay, Juan does not speak. And we wanted to, I wanted to first tell you professionally, I've worked with individuals with intellectual and developmental disabilities my entire life, career of about 40 years. But more importantly, personally, I am a parent of 2 children, adult children with IDD. And I can't emphasize enough for HB 5001 what Sarah Egan said earlier about safety, about staff being places being understaffed, staff being undertrained and underpaid. I don't really need to repeat what she said because she said it so eloquently. But I also wanted to please personally tell you my opinion as well as HB, I think it's 5290 and 5293. Everything that the dentists and doctors just said is 100% true. However, one correction for us personally was we've been waiting between 2 and 3 years for the anesthesia. My son went to the dentist and needed work done. And again, they can't do it in the office. So luckily for us, we live in the Hartford area. So we're able to go to UConn, John Dempsey Hospital in Farmington, which I can't say enough about. They're wonderful. I will tell you that their staff are very well trained to work with people with special needs. However, there's just not enough. You're on this ridiculous waiting list. So when Juan, being non-speaking, he tends to constantly, as you can see, he's biting on a pillow or biting on a toy or biting on something. He had cavities and grinding, and he really needed to be seen. By the time we got the operating room and the anesthesia, it was so bad they had to pull 3 of his teeth, and he had an abscess, and he can't tell me that it hurts. We didn't see the abscess. So that was very upsetting. It could have been avoided. So I just really appreciate that all of this is out there, and people are looking at the importance of it for their safety. And that's it. Thank you very much.
Thank you. I'm going to refer to you as Mom because you're fighting for your children, and we appreciate your testimony, and that is why we feel that we need to keep fighting to make sure you and your family are protected and many other families like you. Thank you.
Thank you.
Seeing no other comments, we will move to the next item on the next general person on the list, which is TJ Clark.
Good afternoon, everyone. To Senator Anwar, Representative McCarthy-Vahey, Vice Chair Senators Kushner and Marks, and Ranking Member Senator Summers and Representative Claridis Dietra, and members of the Public Health Committee. My name is TJ Clark II, Executive Director of Connecticut Oral Health Initiative, located in Hartford, Connecticut. Our mission is to strengthen and safeguard access to quality, affordable oral healthcare services for all Connecticut residents. We desire that all Connecticut residents will have their equal opportunity to obtain the services needed to maintain good oral health. COHI is the only nonprofit organization in Connecticut that solely dedicates its time advocating for equitable oral health policies. Thank you for the opportunity to testify in favor of HB 5293, an act concerning Department of Developmental Services recommendations regarding various revisions to the Developmental Services Statutes. For the 2024 Connecticut General Assembly session, expanding care for individuals with intellectual and developmental disabilities stands as a key legislative priority for COHI. Having engaged with residents across Connecticut, we've learned about the challenges faced by individuals with disabilities and their families who serve as primary caretakers. These families encounter unique difficulties in accessing care constrained by limited resources. As a statewide policy and advocacy organization, COHI is dedicated to collaborating with families grappling with challenges in obtaining oral health care for their loved ones. We recognize the need to empower them to advocate for change, potentially by integrating oral health services into care management models and waiver programs. It is crucial for the Office of Oral Health and Dental Services Unit within DDS to prioritize enhancing oral health and promoting racial equity in Connecticut's public health system. I urge the Public Health Committee to consider favorably passing HB 5293. Connecticut must fulfill its commitment to improving oral health care for all residents. By codifying this unit into state statute and granting the DDS department the statutory authority to provisionally allow licensed dentists to work with DDS, we can enhance oral health access to dental providers in an equitable manner. Failure to pass this bill will exacerbate disparities in our oral health public health system, further marginalizing individuals with intellectual and developmental disabilities. I appreciate the opportunity to present this testimony and implore the committee to seriously considering our perspective. Thank you very much.
Thank you so much, Mr. Clark, for your testimony. We appreciate your insight and absolutely would consider your thoughts.
Thank you very much.
Questions or comments, we will have the next person on our list, which is Dave Fried. Welcome, Mr. Fried.
Good afternoon. I'm testifying on behalf of the Connecticut State Dental Association in favor of HB 5293, an act concerning the Department of Developmental Services recommendations regarding various revisions to developmental service statutes. Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee, thank you for hearing me today. My name is Dr. David Fried, just to correct you, Dr. Anwar. And I'm a practicing dentist, semi-retired. I've been practicing dentistry for over 35 years, served in the Air Force, retired from the Connecticut Army National Guard. And I currently serve on the ADA practice of Council of Dental Practice. I'm a past president of the Connecticut State Dental Association and currently serve as their co-chair for the Council of Government Affairs. I also serve on the Connecticut Dental Policy Advisory Committee and was a Husky provider for many years. I also volunteer part-time at UConn in the dental school. But today I'm here testifying on behalf of the State Dental Association. It is our policy that we support our patients, the health of the general population, and the public health policy. We feel that access to care and qualified oral health practitioners are fundamental to overall general health. After all, the mouth is the gateway to the rest of the body, and good oral health allows for proper nutrition. Finding a job, being successful and feeling good about oneself all begins with a smile. We are in favor of evaluating all avenues of providing care through qualified practitioners, which is what this is about. What this is really about from DDS is they want to make their clinics private that are not considered public health clinics. They want to make them public health clinics. That's what that whole part is about. They want to be able to take providers who are already qualified through other statutes that are foreign graduates or maybe students. They want to be able to bring them out into their clinics that they're establishing so that they can have care. Evidently, I talked to the commissioner before, and he told me that some of their clinics had to close because they didn't have adequate providers. And that's this whole thing is just to make their clinics public health clinics, so that the people who are already qualified to be seeing patients in other places through an alternate pathway of licensure because they're foreign grads. The only thing we're a little worried about is they talk about exceptional qualifications for people applying, and that's a little ambiguous, but it's already, I guess, in the statutes. So we're really happy with it, and I think this should go through. We want to continue our partnerships with DPH and with the DDS. So that's where we are. We're really good with it. One of the things I really want to bring to your attention, which really hasn't been spoken about, is the pressing need for, it's a public health crisis regarding special needs adults and operating room time. Because over the past year or two, the practitioners who have been seeing the special needs adults in the operating rooms have lost their operating room time. This isn't the dentists saying they won't see the patients. This is, there's no facility for them. The hospitals and surgery centers have pulled their time. So there's no place. That's why the anesthesia is very important, because a lot of these people may be able to be seen in private offices if you relieve that, but you still have this big pressing problem that isn't addressed anywhere yet, as far as I know. And I'm just bringing it to your attention that like UConn is evidently full. They're not really accepting any new, and I don't want to get quoted, but that's what I'm hearing, hearsay. I'm hearing that the residencies at Hartford Hospital aren't accepting any more special needs patients. They don't have room. St. Francis evidently isn't accepting new patients. They don't have room. But there are special needs patients out there that are still waiting for care. You've heard already, right? But something has to be done, and it's hospitals are choosing alternative treatments. They'd rather see a couple hips done in an hour and a half versus maybe a single root canal or a couple fillings. It's all
Excuse me, Dr. Freed, but your time is up. Thank you.
I was going to ask you a question. Can you expand a little bit? This is a little different topic, but since you brought it up, I just need to spend a little bit more time. Is your perception that they have the OR available, but they're not providing the operating rooms?
My perception and what I'm hearing from my colleagues who are pediatric dentists who have expanded their practices to continue caring for adults, special needs adults, because that's sort of a part of that specialty. They're telling me that facilities are kicking them out because they would rather have other kinds of procedures being done during those operating times. Okay, so and I can provide you with the exact names of these practitioners who would love to talk with you on the side.
Yeah.
But this is a growing, looming problem that we're hearing across the state, in Waterbury, in Hartford, out in the Tolland area. They're losing their time. And I think that this is kind of part of this DSS bill, but, you know, because it's mentioned in there. But I don't think anything has come to you yet. And I don't think it's, you know, but it's a problem that's coming up, and I think you just need to be aware of it because you're going to have to address it.
We'll definitely look at this and then have more conversations. Perhaps in one of the next sessions, we can look at that maybe more, but we'll have a conversation with DPH and what they can do.
Like I said, it is kind of part of the bill where they talk about it, and it's also related to the anesthesia.
We have a few questions and comments. Representative Claire Teacher first.
Thank you, Mr. Chair. Thank you, Doctor, for being here today. You had mentioned that the hospitals and the surgery centers are pulling time.
Yes,
I mean,
what I've been
do you
told.
think, in your opinion, it's a money issue, that they may or may not be getting more money for a hip or a knee versus
That's
dentistry?
that's what I've been told, is that they've chosen other more lucrative procedures being done during those timeframes.
Okay.
That's
Thank-
what I've been told.
Okay.
You know, I don't have any exact evidence for you.
Okay. Thank you very much. Thank you for being here today. Thank you,
Representative
sir.
Reddington Hughes.
Thank you. My question has to do with the, as a result of this delayed care. I mean, we heard testimonies of others that have, children that have IDD and have been put off for 2 years, 3 years. I just can recall from being in college and listening to the importance of dental health, that it could be directly related to your heart health as well, as you let things happen in your mouth. My question is, as a result of this delay, what kind of effect do you think that this is having on that population? And long-term, what will that cost us?
Well, preventive care is the cheapest thing there is. Yeah, preventive care has been shown to, be the most cost-effective way to maintain health. As things are caught in an early stage and they're treated in an early stage, the cost of treating it is less. We saw many years ago, and I don't want to keep going off topic, but many years ago we increased the Medicare reimbursement rates for children, and we had a really good network put together of providers, and we saw an increased number of patients. It was mostly pediatric because that's where the increase came. And we saw an increase in care, and we saw a really big increase in what the state spent in those first couple years to fix all those wrecks, of those train wrecks of people who hadn't seen care, hadn't been adequately taken care of in the early phases. So you spent a lot of money in those first couple years. And then after a couple years, it normalized out, and you actually saved money in the long run, because children would come in, they would get their teeth cleaned. They might need 1 filling, 2 fillings, just like whatever, and they'd go home. And actually you saw a decrease in what you were spending because we had a really good network. And that's been known throughout the public health sectors as the Connecticut effect. And they talk about it in public health nationally. Connecticut was really the leader in it. And we showed statistically that taking care of things early saves money. And then let's talk about the quality of care. You don't have, toothaches. People don't miss work. They don't miss school. They're happier. They can get jobs easier. Then they're not spending, and you're not spending money for the state trying to get them 2 front teeth or something so they can go on a job interview. So all around, it's good. And the earlier you get to it, the less expensive it is, the easier it is to do. People don't need to be sedated because, it's easy. So
Thank you, Ms.
Thank
Dr.
you.
Fried. Thank you so much.
thank you.
We
Any
don't
other
want to go too
questions?
far. Representative Zupkus has a question or comment as well.
Thank you, Mr. Chair. Nice to see you, Dr. Freed.
Thank you.
Actually, Representative Claritas Deetria got to my question, because I certainly don't know anything about OR time, but is it, if you book in 30 minutes, it's the same price for your time there, or?
Well, I'm not sure about that. I don't do operating rooms, but I believe that hospitals get a percentage of whatever is being done during that procedure in that time. I mean, I'm not exactly sure about how they work,
Right.
but there's a lot more money involved in doing 2 hips in an hour or hour and a half versus a root canal and a filling. And it's different reimbursement rates. So
Right.
yeah, that's what I understood. It was that operating room time is more valuable than what dentists are providing, especially with the procedures. I do know that I think it was last year you increased the anesthesia fees for patients going to operating rooms under the Medicare I believe you
So-
increased that and made it more equitable,
Dr.
but that
Fried, we are
wasn't
like
enough.
too far away from the.
I know, sorry. I'm sorry.
Co-chair is gonna send me a text.
I know, I'm
right
like,
now
I'm
to
probably
say-
last. And,
It's about always following the trail to money.
you know, I know that
Thank
there's
you.
after party with nitrous. Is that what you said over at your
Yes.
house? Is that?
Yes. All
Thank you
right.
very much.
No,
I appreciate
you
all the
so
work you
much.
guys are doing.
Excellent. Thank you so much. Thank you for your testimony. And last but not the least, Eunice Park, welcome. Thank you for staying with us throughout the afternoon and now.
Thank you. I know everybody wants to go home. So to co-chair Senator Anwar, Representative McCarthy-Vahey, vice chairs, ranking members, and other respected members of the committee. Thank you for this opportunity. My name is Eunice Park. I am a resident of New Haven and a Master of Public Health candidate at the Yale School of Public Health. I'm also a practicing pharmacist who has worked in the hospital setting within departments like emergency medicine, where one of my roles was to help identify and appropriately treat patients experiencing overdose from opioid substances. I'm here to testify in support of Raise Bill 5291, the Department of Public Health's recommendation requiring hospitals that treat patients for non-fatal overdose of an opioid drug to administer a toxicology screening when deemed as medically appropriate, and then reporting results to the Connecticut Department of Public Health. Unfortunately, not all opioid substance-related overdoses are correctly identified. A fatality from drug overdose means there are many more occurrences of non-fatal overdoses. And when drugs are suspected to be involved with that overdose, there are common signs and symptoms that are presented in the hospital, but also many cases of self-reporting or lack thereof by the patient. This not only poses a problem of misdiagnosing an overdose that could lead to death, but also misidentifying the legal or illegal drug that actually may have caused the overdose itself. A toxicology screening can help mitigate that ambiguity, but it is not always a routine practice in settings like the emergency department, where patients experiencing non-fatal overdose visit the most. As fentanyl-related overdoses continue to rise from increased illegal supply and demand, it's also important to use screening tests that not only detect illicit drugs and other controlled substances, but can specifically detect fentanyl or fentanyl synthetics, since this is usually not tracked in rapid drug screenings. Data collection from toxicology screening test results help track both the number of non-fatal overdoses as well as the substance that may have caused them. The Department of Public Health can use this to better identify, monitor, and respond more quickly to drug trends in the ongoing opioid overdose epidemic through more timely reporting and analysis of specimen data. It will also help readiness to respond at both the state and national level, which helps coordination with other state health departments, municipal community organizations, healthcare clinicians, government agencies, and law enforcement. In closing, I support the value of this raised bill by requiring toxicology screening tests to be done for non-fatal overdoses and then reporting to the Department of Public Health. This will not only improve surveillance of ongoing opioid overdose crisis, but can also save a patient's life. Again, thank you for this time, and considering my testimony, I would be happy to answer any questions or comments, if any. Thank you.
Thank you, Eunice, for your testimony. And I think this was one of the areas we were trying to explore with the commissioner when she was here. And it's more of a surveillance bill rather than a screening bill. And the thought was that in the community, there should be systems to screen like some of the other states are doing. And while it could be done in the emergency room, but what's happening is when there are organized centers that are in place for harm reduction, that's where all the information is coming out in Europe and in Canada, and now in New York to some degree, but Connecticut is way behind because we have not used the mechanism of harm reduction centers as a place for screening and understanding the new drugs that are in the pipeline. I think that's part of the challenge.
Right.
And because that's a federal funding that's coming, so the Department of Public Health is somewhat restricted in what they can do with the money. And that's why they're using it only for surveillance with a guideline to get consent from the individual. And I think that's the reason that's what we were trying to explore, because through screening, we should obviously de-identify the person and look at all the information and gather what is the drug and the synthetics that are in the market. So, but you're on to absolutely something that is very relevant, and from a public health point of view is a good thing. Because of the funding, I think this bill may not change that.
Yes, I agree. And as I mentioned at the latter end of my testimony, this is, I do recognize that this is for surveillance purposes, but I also feel like this has a clinical significance as well of the importance of toxicology screening to be done, and also the importance of that data being utilized for the, to contribute for the opioid epidemic surveillance.
Yes, yes. Good. I love this combination of pharmacist and emergency room pharmacy work and also public health.
Okay, thank you so much for your time,
Say
everyone.
hello to Shelley for me.
I will.
Okay,
Thank
thank
you.
you. And with that, thank you so much. All good things have to end. So we are gonna adjourn a public hearing. Thank you, everyone.
Thank you. Have a great weekend, everybody.
Oh, okay. That's history here. That is absolutely history. I will. Right.